All right, good afternoon, everyone. We're going to get the program started just in the interest of keeping the integrity of the program intact. We want to have this flowing, and Dr. Heinert will be joining us. But first and foremost, hello, and thank everyone for joining us here in person and virtually today for the COVID and IACCI Clinical Implementation Forum. My name is David Mormon, as I just said, and I'm going to be your MC for today. And the event is part of the Chesley Initiative's Education and Awareness Campaign, launched in 2023, 3 years ago. And we want to make sure that you're comfortable for the duration of this event. It's a beautiful and a hot day, so please feel free to stretch as needed. We do have doors that are open on it. The lobby door will probably be closed, but you can go outside, get some air as well. And before we begin, I'll briefly review a few key items and provide an overview of today's session. I do have a couple of slides that I'd like to say. I've got slides from the California Medical Association. Okay, and this activity has been accredited through a joint providership with the California Medical Association. And then slide number 2. The following relationships with ineligible companies were reported. These relationships have been mitigated. All other individuals in control of the content were found to have no relevant relationships. Okay. Today we'll be hearing from leading experts across clinical care, research, and patient experience to deepen our understanding of long COVID and infection-associated chronic conditions and illnesses, or IACCI. Okay, and we've got an amazing list of our communities and our nation's healthcare leaders that are going to be speaking here to us. And this forum is designed to create space for open dialogue, shared learning, and collaboration, bringing together perspectives that are often silenced but deeply interconnected. I'd like to thank all the organizations that have supported this endeavor: the County of Santa Barbara Health Department, CenCal Health, the James S. Bauer Foundation, and Cottage Health. Now we're going to start with welcoming remarks and a keynote address, followed by a short break for refreshments. Then we're going to return for a physician panel and another brief break. Can't take too many breaks, and conclude with the patient panel. I find that one to be particularly of interest, as many of the patients live here in my local community here in Santa Barbara. Now, if you're joining us virtually, hello to all of our virtual attendees. Please submit your questions in the chat, and they will be relayed to us here. Now, without any further ado, I'd like to welcome to the stage the Health Director of the County of Santa Barbara, Dr. Muhammad Mahami. Please come on up, sir. Dr. Hamami. Thank you.
Oh, I guess you can hear me now. Well, welcome everybody. Thank you all for being here, both in person and virtually. It is an honor to welcome you on behalf of all our partners who came together and made this event possible. It was just a few years ago when the world was still grappling with a new pandemic, and while everybody was trying to address the acute conditions that were caused by COVID-19, there was something that was happening in the background where people were not fully aware of. These were things that happened more chronically, things such as fatigue, symptoms, and memory lapses, and others. And this is where people started looking into some conditions, and this is what we now have known, or we became to know, as long COVID. However, that journey did not happen overnight, and while a lot of skepticism, a lot of misinformation, as well as a lot of denial did accompany such conditions, we stand here after 3 years to acknowledge that long COVID is now real, and there is a great community that is addressing what it means, from clinicians to researchers, but also patients as well. And I want to credit the voice of patients and the voice of community, because without that, a lot of where we are now would have not been possible. We have made a lot of strides. We are today celebrating a provider's manual, which is a great accomplishment, where it will add to how we manage long COVID and how do health practitioners as well look into how they can benefit their patients and how they can serve them better. And that is a great, great accomplishment. However, it is not over yet, and we still need a lot of effort, we need a lot of education, and we definitely need a lot of research. And for us to be here together with all the people that are looking into long COVID, this is definitely something that we need to continue, and it makes me very proud and happy that we are part of this effort. So again, I welcome you all and thank you for being here. It is also my honor and pleasure to introduce Dr. Maya Heinert, who is the Chief Medical Officer for SynCal Health, a fellow Michigander. Dr. Heinert is in charge of ensuring the quality and access to care for almost 240,000, not 24, 240,000 patients that reside in Santa Barbara County. Dr. Heinert holds an MD from Wayne State University, where I used to be as well, so a lot of interactions there. And she holds an MBA from California State University in Sacramento. Dr. Heinert.
Good afternoon. I have the very fun pleasure today of getting to welcome you to Santa Barbara. Most of you know Santa Barbara because of our amazing natural beauty. But those of us who have the pleasure to work and live here know that the real wealth of this community is from the people who live here. I've noticed a couple of things about the people in this community, and I haven't always lived here, so I pick up on differences in different parts of the country, Michigan, many other states. One thing is imagination, and the other is attitude. And the combination of imagination and attitude get a lot of things done, and this is a community that gets things done. We have art, music, we have literature, we have research, universities, science, we have beautiful fields that make food that help feed the nation. But in this pocket here of beauty, there's also people that are underserved. And SynCal Health, as Dr. Hamad mentioned, SynCal Health, which stands for Central California Health, serves San Luis Obispo and Santa Barbara counties. And we have one single mission, and that is to ensure that even the most vulnerable people have access to health and a full life. And that's what we do. We use Medi-Cal dollars for that, but we don't do it alone with Medi-Cal. We do it with all of you. Those of you who showed up today, one way or another, are connected to the work that we all collectively do to ensure that we have a healthy community here for everybody. I want to end my welcome today by a quote that I heard. I love to listen to podcasts. I am driving a lot. We've got big communities here, big counties. This was recently on Freakonomics, a Freakonomics podcast. Fun podcast. They interview lots of interesting folks. And recently they interviewed Professor Joel Macher. And Professor Macher is a professor of history and economics at Northwestern University. And he recently won the Nobel Prize in economics for nothing less than the study of human progress. Professor Macher said, "It is quite clear that progress is driven by a very small proportion of the population. 2.5, maybe 3% of the labor force are driving all the progress." And Macher's argument is that this small percentage do that by changing culture. He went on to say that most of us benefit from that progress, but at first, there's always resistance. There's always fear. Any change, it's human nature. If we haven't heard of it, we don't believe in it, our mother doesn't know it, we're suspicious, we're skeptical. So the group sitting here today, those of you who chose, through your own free will, to come here on a Saturday, a beautiful Saturday, for the sole purpose of expanding your outlook, broadening your mind, learning more, I hold that all of you here today, and those of you who are remote, watching on video, this time is that you have dedicated, that you are part of the 2 to 3% that is driving human progress. By your support of those of us that are leaping forward, we can't all be research scientists, we can't always be the one discovering things, but we can support those things. And so I applaud all of you, and it's my warm welcome to you. Thank you for being here. I am certain that I'm going to introduce someone very distinguished. Is it you, Chesley? Oh, well, then that's my pleasure. I would like to have the pleasure to introduce someone that is probably well known to you already. Chesley Hemsfeld is someone who is definitely in that 2 to 3% of humans who is helping us progress. So, Chesley, thank you.
Good afternoon, everyone. Thank you so much for being here. And I just want to take a moment to sincerely thank Dr. Heinert and Dr. Hamami for providing the pillars of support and compassion to make this all possible. Let's give them a round of applause. So, my name's Chesley, and by total coincidence, I am the executive director of the Chesley Initiative. And in 2017, I was interviewing a very respected researcher at Stanford University for a PSA video that I was directing. And he said something to me that I will never forget. He said, if there were to be a pandemic, a significant number of people would fail to fully recover and go on to develop ME/CFS. And because we know that when certain people get Epstein-Barr virus as adults, about 10% of them fail to fully recover and go on to develop ME/CFS, that if there were to be a novel virus, there's a likelihood that there would be a higher frequency of conversion. And that means we would end up in a mass disabling and economically catastrophic event. Fast forward 2026, I think we all know several of these predictions to be true. We know that 10 to 26% of people that get COVID-19 go on to develop long COVID. That's over 400 million people around the world. That's likely an underestimate. And we also know that throughout history, there have been cluster outbreaks that have happened where people get an infection and some of them fail to fully recover, developing these constellation of disabling symptoms. This has happened in Los Angeles in 1934, in London in 1955, in Incline Village in 1984, in Lyme, Connecticut in 1975, and so on and so on. But it also happens in individual cases like my own. I was a freshman at Emory University when I got an infection, and I could not heal. I went to the school nurse, and when she did not know what I had, I knew instantly that it was going to be life-altering, if not life-threatening. And I spent the next 10 years of my young life looking for an answer, trying to just get a diagnosis. And finally, I went to a walk-in urgent care clinic in Hollywood, and the doctor took out a Sharpie, and he said, "Do you hurt here, 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 and here?" And I said, "Yes, yes, yes, and yes." And he said, "You have fibromyalgia and ME/CFS." And he opened a medical glossary and put it on the exam table and walked out of the room. And I thought, oh my gosh, I cannot believe that I finally have a name, or rather names, for what I've been experiencing, that I made to feel like I was so alone, stumbling in the dark. And we don't want anyone else to experience that like I did. This is why I have such a haunting sense of urgency to ensure that everyone in the whole world knows what you're going to know today. So you are an essential ingredient, and together, and especially in this wonderful community in Santa Barbara, we've been able to build a patient-centric and community-based education and awareness model that can scale and serve as a blueprint for the nation. So we hope that you will all join us in supporting that effort. I'd like to thank all of our incredible supporters, our team. Many of our team are patients themselves, anyone who helped get us here, and of course, our wonderful speakers today. So thank you so much, and I'd love to introduce someone who's also a very special part of the 2%. So is it 2%? And this is Dr. Leslie Lynn Pawson, and she's been a valiant education champion, and she truly cares for her patients. Thank you.
Good afternoon, and welcome. I'm a family physician. I've been a family doctor for well over 40 years, and I've absolutely loved all of it. Patients that suffer from symptoms that are associated with infection-associated complex chronic illnesses usually seek out their family doctor or other primary care provider as their first contact for their illness. Family doctors are the expert generalists. Family physicians take care of people with chronic, complex illnesses all the time, and they do it well. Family physicians and other primary care providers need to take this on. They need to take on these chronic illnesses. I'm going to spend a few minutes to try to make the case for why we need forums like this to help us do that. So, the first patient I'm going to talk about is in their 30s. Symptoms, they had COVID infection, in late 2021. And symptoms consistent with long COVID began early 2022 and worsened throughout 2022, including myalgic encephalitis, chronic fatigue syndrome, postural orthostatic tachycardia syndrome, MCAS, and more. This person struggles throughout 2022 and 2023 to find care. They encounter disinterested, very busy physicians. They encounter interested, caring, busy physicians, but with no expertise. All the centers with expertise and diagnostic abilities are an exhausting distance from home. Pre-COVID, this individual was physically very active, worked full-time in a very demanding and stimulating job. Post-COVID, they spent a lot of their days in bed in a semi-darkened room. They had marked post-exertional malaise and worsened brain fog with even minor physical or cognitive strains. They went through a period of time where they obtained their expert care from out-of-state centers remotely, resulting in problems prescribing meds. They encountered long waits for in-state, but still very far away expert centers, probably very familiar to many people listening to this today. What would have made this patient's course easier? Keep that question in your own head. Next patient. They're in their 40s. In early 2024, they present to their family physician with dyspnea on exertion. It had progressed over the previous 10 months. Review of system revealed all those symptoms: intermittent nausea, frequent headaches, dizziness, dry cough, and abdominal bloating. Now, they are so dyspneic that climbing stairs in their home is extremely difficult. Their initial workup, their electrocardiogram is normal, their chest x-ray is normal, they have no physical findings of heart failure, they're not anemic, their thyroid works okay, their coccidiomycosis titers are negative. They have a transthoracic echo, it's also normal. Oh. Come on. Let's get that up here. Their report reads like any other normal echocardiogram. They have a CT of their chest without contrast, no abnormalities. Pulmonary vasculature is not well visualized because they didn't use IV contrast. They have pulmonary function tests, Remember, this person is so short of breath, they have a hard time climbing up the stairs. They were also normal. No significant post-bronchodilator response. Whoops, back. Then they encountered a physician who had a high index of suspicion and asked them, did you have COVID-19? And if yes, when? And the answer? Sure did. Fourth time was immediately before the shortness of breath began. So what does this patient need now? Keep that one in mind. Next patient. This person's in their 50s. In late 2020, complained of marked fatigue. They were sleeping 10 to 12 hours a night without feeling refreshed. There's no note in the medical record regarding the presence or absence of COVID infection. In early 2021, there's a note by a family physician in their chart that they're considering chronic fatigue syndrome. Patient also has diffuse body pain. Later that year, actually it's 3 years later, post-exertional malaise is noted in the chart. That patient, it's suggested to them to reach out to something called the Open Medicine Foundation in Agoura Hills. The patient finds out that it's a research facility and does not see patients. It was indicative of their primary care physician not knowing what resources to help them with. Around that same time, they're also diagnosed with MCAS by their allergist. There's no notation in the consult note suggesting the physician was thinking about an infection-associated chronic complex illness. And they're placed on histamine blockers. Time goes by. This person describes intermittent episodes of profound fatigue since early 2020. And patient blames the onset on an MMR vaccine received in early 2020. Denies ever having COVID-19. And remember in early 2020 how difficult it was to get a test for COVID? So is it possible that they had symptoms of a relatively mild COVID infection and they blamed it because it was temporally related to having had their MMR vaccine? Possibly. In late 2024, they see a rheumatologist. The rheumatology consult, because of fatigue episodes, accompanied by body pain. The patient describes the following. Every 5 or 6 weeks, they have head-to-toe body pain. They're unable to bear weight. They're bedridden for 5 days at a time, and they have excessive and non-restorative sleep. Conclusion, there's no rheumatologic etiology for this. Another year goes by. They're seen by an allergist. They again describe the full body flares 2 or 3 times a year, where they're bedridden for 5 to 7 days, and it's been occurring for 5 years. For 5 years, that puts us back in 2020. What does this patient need now? That patient needs what we need. They need physicians and other providers trained to recognize the myriad of symptoms that might be secondary to an infection-associated chronic illness. They need primary care physicians and subspecialists and other providers to have a high index of suspicion to include an infection-associated chronic complex illness in their differential. They need those same primary care physicians, subspecialists, and other providers to be competent in performing systematic assessments of patients with those symptoms. And they and we need expert resources close to where our patients live. They need resources where their primary care physicians can get expert advice with medication management and non-pharmacologic management. We need resources, we need to be able to refer people to skilled physical therapists that know how to care for people with infection-associated chronic illnesses. We need a lot. We need physicians to be aware of online resources, such as what we're going to be introduced to today. The Cohen Center for Recovery from Complex Illnesses' new manual, new provider manual, infection-associated chronic illnesses provider manual. We need to be familiar with the Bateman-Horn Center's clinical care guide entitled Managing ME/CSF Long COVID and IACCS. We need online courses, such as Stanford Medicine's. Get this up here. Such as Stanford, well, too fast. That's a beautiful picture, though. Oh, can we go back? I want people to see it. So we need Stanford Medicine's Unraveling Long COVID, Clinical Advances in Future Directions, as well as the University of California's Health Long COVID and Education Program. Those are available to us. We need physicians to know about them. We need physicians to take them. That's okay. So now I'm going to introduce you to our keynote speaker, Dr. David Petrino, who is the director of the Cohen Center for Recovery from Complex Illnesses. He is going to introduce us to some of the tools that I have just said we need in order to do a better care, to be able to better care for this patient population. Thank you.
All right. Hi, everyone. How's everyone doing? It is an absolute honor to be here, and thank you to the Chesley Initiative for bringing me here. Thank you to everyone for filling up this room, showing us that there is, in fact, interest in education around these issues. Thank you, Dr. Pawson, for such an amazing introduction to the reason that we need to be here talking about these issues. What I'm going to do is I'm really going to encourage lots and lots of questions about novel, innovative, bleeding edge therapies for infection-associated chronic conditions and illnesses, because this is a CME accredited event. And you know, one of the things that I just want to name from the outset, because I'm problematic and I like to do it, is, you know, as we were getting CME accreditation for this event, all of my slides that were showing evidence-based, so published interventions for long COVID, ME/CFS, et cetera, the sort of CME accredited people were saying, oh, no, you can't put that in, you can't put that in, you've got to cut this out, you've got to cut that out. So we're going to have a pretty easy talk here, but then I want to encourage lots of people to ask me, you know, what's going on in the real world, in the clinical world, as we're trying to treat some of these conditions. So, but let's start off nice and easy, because I think that these topics can get murky very, very quickly. I always like to start off, you know, the acronyms are always changing, and we're now talking about IACCIs. This is the latest administration, Department of Health and Human Services, talk about infection-associated chronic conditions and illnesses. And again, I think people can get confused with the changing terminology, but we like to keep it very, very simple. An infection-associated chronic condition or illness is a disease state where somebody fails to recover to their previous health baseline after an infection event. That's it. So you were previously healthy, something happened. You were exposed to something, you got sick with something, and although a lot of people who get sick with the same thing or get exposed to the same thing manage to bounce back to their pre-exposure or infection baseline, you've failed to do so. You can now be diagnosed with an infection-associated chronic condition or illness. And as we start to think about which one you should be diagnosed with, what we try to do in the clinic as much as possible is really focus on the existing diagnostic guidelines that are out there already, because they are out there and they are quite good. And then, we'll also delve into the complexity that surrounds these illnesses and how you can help even when you don't necessarily know what the perfect diagnosis might be. But let's start off simply. So when we're talking about the diagnosis of long COVID, the National Academies published a really comprehensive clinical case definition. And, the very simple piece of it is if you survived a COVID infection and you failed to return after 3 months to your pre-infection health status, you can be considered to have long COVID. So that's the sort of, basic line in the sand. What differentiates people with long COVID from other infection-associated chronic conditions and illnesses is the SARS-CoV-2 infection. That was the triggering event, so that is what guides you toward a long COVID diagnosis. It's also important to note, and something that I really liked in this particular clinical case definition, was they encouraged providers who are making the diagnosis to understand that long COVID can manifest as single or multiple symptoms. So someone may come to a provider, hopefully a PCP or a family medicine doctor, and say, listen, I got COVID 4 months ago and I'm just fatigued all the time now. I'm fatigued and I have headaches. So it can be a single or it can be multiple symptoms, or it can be single or multiple diagnosable conditions. So it may not be necessarily, I got COVID and now I'm fatigued all the time. It may be, I've got COVID and I meet the clinical diagnostic criteria for POTS, postural orthostatic tachycardia syndrome. So you can be diagnosed with POTS secondary to your diagnosis of long COVID. But again, the National Academies always guides us back to what triggered this change in your health status. And that is how you should think about making the correct diagnosis as you go. And so this is how we think about it in our clinic. Of course, lots of people have different opinions on how to do things, but this is how we tend to sort of consider what we're doing. And then the final thing I just want to name here that I think is really important is we always hear a lot about biomarkers, especially when we're talking to insurance companies. They're saying, well, what biomarker did you use to diagnose long COVID? And we always reply back to the insurance companies, well, we don't need a biomarker. The CDC and the National Academies tell us, and the World Health Organization, for that matter, and the NIH, all tell us that a biomarker isn't necessary. So what we need is a clinical history of SARS-CoV-2 infection and then an onset of disabling symptoms. So this is how we think about long COVID. I'm also throwing this slide into the mix, which is horribly busy, and it's busy for a point. I wanted everyone to see how sometimes we sort of can build all of these very, very complex models around diagnosis, but effectively, if you read through this publication that we put out just last year about how to diagnose chronic Lyme disease, it says PTLDS up there because, once again, we had to change the name, but if you speak to our patients, they prefer the term chronic Lyme disease. Really what it's telling us is how closely can you link the change in health status to a interaction with a tick or a vector that carries Borrelia, which is the bacteria that causes Lyme. So once again, it's onset of new symptoms that are disabling, and how closely can you link it to interaction with a tick? As you can see here, there's group 1 where it's just very well defined. It is someone who was bitten by a tick, tested positive for Lyme disease, took antibiotics, failed to recover. And then it goes all the way through to, hey, maybe you were in a Lyme endemic area, maybe you got bitten and you didn't realize it, maybe. But also, once you're in group 4, maybe you should be also considering other diagnoses that might fit your symptoms better. And so, once again, we're being encouraged to link it to a triggering event. What is the triggering event that caused the initial onset of the symptoms? And maybe consider that the person never fully recovered from that infection or that exposure. And then start to look for reasons why, which we're going to get into shortly. Then we have ME/CFS. We diagnose ME/CFS in our clinic, and ME/CFS is a great diagnosis for folks who certainly in many times are unable to name the triggering event that caused their illness. But we still have really clear guidelines about the presentation of symptoms. So as you can see here, we're given a set of symptoms that are associated with ME/CFS using the Canadian consensus criteria, which is what our clinic uses for diagnosis. And in addition to the onset of these symptoms, we also need to check for other things. So it is actually quite a rigorous protocol to get an ME/CFS diagnosis. So the first thing is that the symptoms need to be new onset. And when we say new onset, we don't mean the person is coming in and it's been exactly 6 months and now you can make the diagnosis. When we say new onset, what we mean is the person can come to you 10 years later, but they can remember a time when they were well. So they can remember a time when they were well, they were healthy, or they were living at a health status that they were comfortable with, and then an event happened. Maybe they don't know what the event is, maybe they do know what the event is, but that caused the change in their health status. So that's number one. Number two, we clear mental health diagnoses and other physical health diagnoses as well as a potential cause of the symptoms. Now, I want to be really clear here that many people who have been sick for a long period of time with uncontrolled symptoms may also experience depression, may also experience anxiety. We can understand that someone can have depression and anxiety because of their symptoms, and that they are not the reason for the symptoms. And so our providers are always very skilled about screening for mental health conditions that are co-occurring with the condition, but also understanding that, yeah, of course you're depressed because your quality of life has changed so dramatically, or you don't feel in control of your symptoms, but the depression happened after you started to experience such severe symptoms. So it doesn't affect your ability to make the diagnosis. And then this is a really important piece of the puzzle. We need a functional impairment that goes below normative thresholds for 2 of the 3 subscales of the SF-36. Now, this is a really nerdy condition, but I think it's really important to sort of to name this one, because this is really the condition that means that you don't get dismissed because, oh, you're just getting older. So you show up to the doctor and you say, I've got chronic pain and I've got this going on and I've got that going on, and they say, oh, well, that's just normal aging. The SF-36 is a functional outcome measure that tells us what should be, normal functioning levels for someone of your age, of your gender, et cetera, et cetera. And if you're coming below normative levels, absolutely the disability that you're experiencing from your symptoms is not due to normal aging. So it allows us to completely push that out of the way and say, no, this is abnormal. The fatigue you're experiencing, the post-exertional malaise, the pain, the other symptoms. So we need to do something about it, and we need to start exploring active treatments. So I wish it were all that simple, but of course there is complexity in making the right diagnosis. And, you know, all we have spoken about so far is how we diagnose when there is a really clear history and a really clear proximity to a triggering event. So we've only spoken about what happens when, yeah, you definitely had COVID, you were doing quite well before COVID, now you've had COVID, you failed to recover, or some other, you know, you were bitten by a tick, very clearly had a bullseye rash, now you're not recovering. What happens when there's a little bit of distance between the triggering event and the onset of illness? Complexity does start to ensue. You can still use the existing guidelines, but we need providers who are trained to be able to take a history that can lead them to the right diagnosis. We often see infection-associated chronic conditions and illnesses emerging not after an infectious trigger, but after a non-infectious trigger. There's a lot of precedent for this. We hear about ME/CFS patients experiencing their first sort of real serious crash after a traumatic event like a car accident, a surgery. And when I say traumatic, I can mean emotionally traumatic, or I can mean just physiologically traumatic. So people had a knee surgery, and ever since they woke up from their knee surgery, they've had what really meets criteria for ME/CFS. So there is a lot of precedence for this. In the literature, you'll actually see that many triggers can be, you know, chemical exposures, medication exposures, and we call this in the literature a sort of, it's called the multiple hit hypothesis or the successive hit hypothesis, where we understand that a lot of the physiological drivers of symptoms in infection-associated chronic conditions and illnesses are related to neuroimmune dysregulation. And what might happen is, you know, over a period of time, first you get an infection, then you go through a stressful period in your life, then you know, unfortunately find yourself in a physically traumatic situation like a car accident, and these hits build up on your sort of what we call allostatic load, your body's ability to sort of like regulate physiological stresses, and something tips you over the edge. And now you're in this disease state that we call ME/CFS. So I want to name the fact that there is a lot of room for complexity, and sometimes this, you know, the providers who are making the diagnosis need to go a little deeper and understand that, you know, some of these triggers can be, you know, a little bit more distant from just an infectious trigger or just a tick bite. You know, there could be more to it. And to make matters worse, you know, because there's always no shortage of bad news here, sometimes, you know, you can be really sure of a very obvious diagnosis, and it may not be the best diagnosis for your patient. This is a paper that I share a lot because it's on my mind a lot. It's a case study of a patient in France who perfectly met diagnostic criteria for long COVID, meaning living healthily, no problems, no issues, sustained COVID, started to experience a significant drop in their quality of life, started to develop all of these classic long COVID symptoms, fatigue, cognitive impairment, headaches, etc. Was really unresponsive to anything the providers were trying. And then when one of the providers tested them for Bartonella, which is a bacteria that is carried by ticks. It is also carried by cats. You often hear about Bartonella with cat in the context of cat scratch fever. This individual was positive, treated with antibiotics for Bartonella infection, and made a full recovery. So we know that many of these pathogens have the ability to reactivate other pathogens. So you may survive your SARS-CoV-2 infection just fine, and you may clear that SARS-CoV-2 infection from your body, but not before it reactivated your EBV, your Babesia, your Bartonella, and some other pathogens that have just been waiting around to cause some trouble. And so this is also something that we need to be mindful of, and that we train our clinicians to sort of think about in terms of, if someone is not following a recovery trajectory that you would expect. So if you feel as though you've dialed in on the problem that is driving some of their, let's say, long COVID symptoms, and they're really not moving the needle, and it's now been 4 weeks, 6 weeks, 8 weeks, maybe you should consider looking into some other drivers, or, or the fact that SARS-CoV-2 has triggered something else. And again, I warned you I was problematic, so just to make things even worse, we really don't test for a lot of the pathogens that can cause problems in people. And I think what we need to do as a collective is start being a lot more rigorous about all the different pathogens that we know that can be reactivated, that we know can sort of sit quietly in people's bodies for years until another immune trigger causes them to reactivate, and just educate ourselves on them and be aware of them. So I think that this is a list of pathogens taken from a recent study that really just reviewed the literature around all the human-affecting pathogens that a single tick can carry. So we only ever think about Lyme disease, which is Borrelia, but here are all of the things that a single tick can carry, and it's not just limited to ticks. Dust mites can bite us, other vectors, spiders, etc., mosquitoes. And so what we need to be aware of as we're getting more and more educated about infection-associated chronic conditions and illnesses is this domino effect of one trigger causing another trigger to emerge. And again, once we're thinking, okay, this person isn't responding the way I thought they would, we need to start testing for some of these still well-known but less investigated pathogens. And then what that means is we need to prioritize access to better testing, because there is good testing available, but it is by no means mainstream, and a lot of it is research only, and a lot of it is only available in certain states. So this is something that I think we need to democratize much more effectively. And I just want the final point on this sort of diagnosis section to really, again, just name the fact that every day there is a new paper coming out showing that SARS-CoV-2 reactivates different bacteria, different parasites, so we need to be aware of the fact that this virus that is pretty much freely spreading through our population at this point has an uncanny ability, one that we haven't seen before in other viruses, other respiratory viruses to this degree. It has an uncanny ability to be very effective at reactivating pathogens. So we're going to just spend a couple of slides. We could have a whole lecture on this, but we're going to spend a couple of slides just digging into the pathobiology of long COVID. The first thing that I want to talk about is the fact that there's been a lot of studies. I'm going to list one study which I think still to this day is a nice comprehensive look at all of the symptoms of long COVID. It's again a busy slide for a good reason, to really point out that we have over 200 symptoms associated with long COVID. Long COVID is known in multiple studies. This has been validated. This was the original study, I think, that had the most comprehensive list of over 7,000 people reporting symptoms from many different countries. But we now have publication after publication validating the fact that long COVID can affect every single organ system, and it can present in a diverse number of ways. When we're training our medical students at Mount Sinai on long COVID, we're always saying that, the sort of adage of if you've seen one long COVID patient, you've seen one long COVID patient. There's no one size fits all here, and that is true across all infection-associated chronic conditions and illnesses. And so rather than thinking, when we're starting to try and understand what's happening in the body to drive these symptoms, rather than thinking in terms of fatigue. So, a question I always get is, why do people with long COVID have fatigue? That's really the wrong question. The right question is, what could be happening in the bodies of people with long COVID? What are all the ways that people with long COVID might be experiencing fatigue? And so in our handbook, which we weren't allowed to list in this CME accredited presentation, because it is not peer-reviewed and published, although it is available on hhs.gov. Don't know how those two things resolve, but if you go on hhs.gov, you'll find our handbook, which is totally free, 165 pages of pure joy of reading. We listed out 10 key drivers, and every single one of these drivers we listed only because there were dozens, if not hundreds, of peer-reviewed publications validating the fact that these are things that can be causing symptom burden in long COVID. Just to briefly go through, go down the list, we've got probably the most obvious one, which is SARS-CoV-2 persistence. Someone got infected with the virus and just failed to clear it. It never went away. We've got latent pathogen reactivation, which I've now bored you all to death with, for 20 minutes or so. You were infected with the virus, that virus went away, but it reactivated a bunch of other viruses before it left. We have mitochondrial dysfunction. These parts of our cells that produce energy start to get dysregulated. They get damaged in the infectious process, and they're not able to recover from that damage. And now they cannot produce energy the way that they used to, efficiently or enough energy, and they cause problems. We've got vascular and coagulation dysfunction. So we have seen, again, there have been hundreds of peer-reviewed publications now showing us that spike protein agitates the endothelium, the inside linings of our blood vessels, and can cause inflammation, microclotting, and all sorts of dysregulation to the endothelium, which can then go on to cause downstream issues with microvascular problems, organ dysfunction, etc. All of which is notoriously hard to identify with standard clinical testing. Dysautonomia and POTS. The virus can directly and indirectly cause damage to the autonomic nervous system, which is the part of our nervous system that controls things that we typically don't have to think about: heart rate, blood pressure, digestion, etc. And then on the other side, we have neuroinflammation and cognitive dysfunction. We published a paper early in 2022 showing that even mild SARS-CoV-2 infection that does not leave the lungs can result in the release of inflammatory chemicals that cause white matter damage in the brain. So even a very mild SARS-CoV-2 infection can be causing neurological damage and can be causing persistent neuroinflammation. Immune dysregulation, so some folks can go in one direction where their immune system becomes less effective at fighting off pathogens. Their immune system can also go in the other direction, the direction of autoimmunity, where their body can start overreacting to latent, intruders in the body, so pathogens that may be there but just aren't dangerous, or even their own body tissues. We have gut dysbiosis, so the sort of just general buildup of our gastrointestinal bacterial growth gets dysregulated and starts causing problems. We've published multiple papers on hormone dysregulation related to long COVID, and we also have, we see that long COVID is frequently associated with what's called mast cell activation syndrome, where mast cells, which are immune cells that fight off infections and invaders, can start to uncontrollably release many sort of inflammatory chemicals and histamine that can cause all sorts of problems. So all of these drivers have extremely good evidence behind it, and it's the challenge of clinicians who have a long COVID patient in front of them to try and understand which of these drivers are at play by adequately testing physically and through blood tests and through just a good comprehensive physical exam, and then start to attempt to treat based on what their tests are telling them. But then, because again, I keep warning you how problematic I am, and no one seems to believe me, but we also talk about long COVID and other infection-associated chronic conditions and illnesses as dynamic disabilities. And I think it's really important to note that these drivers can shift and change day to day. So what someone may be testing positive for one day can change entirely overnight. And that can be dependent on hormonal function. So for people who menstruate, as their hormones are cycling, some days they may be testing positive for every pathogen under the sun because their immune system is a little weaker, and then their hormones cycle again, and suddenly their immune system gets a little stronger, and they're testing negative for everything. So this is often baffling to many providers, but it shouldn't be baffling, because we are not existing within this little sort of silo or this little sort of time capsule of when the blood was taken. These complex chronic illnesses are a part of the complexity is the dynamic nature of them, because we aren't static, we are dynamic organisms. And so there is a critical need for sort of constant monitoring of these patients to understand how their illness is changing day to day. So we're now going to dig into some thoughts about long COVID management. And for this section, I'm really going to talk about what we do personally in our clinic. Obviously, what we do is what we do, and take what you find useful, leave what you don't find useful, and that's the spirit of sharing how we're trying to manage these folks. So our treatment philosophy is pretty straightforward. We don't want to treat symptoms, we want to treat drivers. We don't want to be sort of playing whack-a-mole with let's give everyone the same treatment for fatigue. We want to think closely about what could be driving the symptom behind, what is driving the symptom behind what the person is reporting. So we listen to our patients. That's step one, right? That's pretty straightforward. We then investigate. We investigate in two ways. The first is if somebody comes into the room and says, I'm fatigued, we don't just write down patient complains of fatigue. We say, patient reports fatigue because they're not complaining. And then we say, let's find out how fatigued they are. So we use something like the fatigue severity scale, which gives us an objective measurement of the fatigue that's being reported. In parallel to investigating the severity of the fatigue, we're also looking into what might be driving the fatigue. So if somebody says, look, I'm fatigued all the time, and you start to ask questions and they say, well, it is worse when it's hot. And yeah, when I go from sitting to standing, I do feel my heart beating in my chest quite a bit. Okay, you take note of that and you say, maybe this person should get some autonomic testing. Let's get them on a tilt table. Or if we don't have a tilt table, let's do an active stand test where all you need is a blood pressure cuff and a wall. So it allows, as you start to think in this driver, from this driver perspective as opposed to a symptom perspective, you start to break down, okay, what do I need to sort of rule in or rule out a driver that I'm concerned about? As you start to investigate, hopefully you're going to find a cause. Hopefully you're going to say, yep, this person has POTS, and from the looks of it, we're going to call this hypovolemic POTS because when they stand up, their blood pressure sinks into their boots and their heart rate goes up. So we're going to give this person fludrocortisone. We're going to give this person LMNT and electrolytes. We're going to give this person, thigh-high compression stockings, and hopefully this is going to stop the symptoms, and that's how we treat. None of that is, CME approved, but that's kind of what we do. So, first principles. As we're starting, so we move beyond lift. That's the philosophy. Now we're going to think about first principles. And in our first principles, it's always about, obviously doing no harm when our patients come in. So first is you're dealing with a group of individuals who have proven immune dysregulation, who have proven vulnerabilities to external pathogens. Protect your patient. And be sensitive to requests to wear a mask as well. In addition to this, I would say if you have the means and if you have the resources, stack your protections, good ventilation, HEPA filters, they don't cost that much. Things like far UVC lighting, which we use in our clinic, that are germicidal, so they eradicate pathogens whenever they're sort of free-floating in the air. These are all ways that we can be protecting patients. Which is the next point. Also, don't psychologize biological illness. So don't tell people that are coming to you with legitimate disability and legitimate pain that this is all just a part of getting older and they shouldn't worry too much about it. Don't infer that perhaps this is all because they're very upset about something else that is going on in their life that is very stressful, that doesn't really have anything to do with what's going on. As I said earlier, of course, many folks with these diagnoses are going to come to us with legitimate concern about their future that can look like anxiety, that can look like depression, or can be anxiety and can be depression because they've been sick for so long and they don't really have any options. But one of the, I'll give you two really important publications here. One of the lead reasons for people with ME/CFS to experience suicidal thought and ideation is not being believed by their provider. So this was a large survey of thousands of people with ME/CFS who said the number one reason that they will feel suicidal after a medical appointment is when they're being told that perhaps have they considered that their illness may be psychogenic. So that's number one. Number two, which I think goes hand in hand with this, is in a study that was published in Nature Psychology that looked at the adaptive coping skills of people with ME/CFS and long COVID compared with age-matched healthy controls. That study showed that people with long COVID and ME/CFS have better adaptive coping skills than their age-matched healthy control counterparts. This is actually a common thing seen in the disability world. So folks with disabilities often have to develop adaptive coping skills that allow them to sort of live in a non-disabled world with a disability. So we know about this. There's many years of literature in spinal cord injury, traumatic brain injury that show this, but it was also shown in long COVID and ME/CFS. And the lesson that teaches us is the vast majority of our ME/CFS and long COVID patients do not need cognitive behavioral therapy, which is a treatment designed to teach adaptive coping skills. Some do, and that is a decision that can be made by an informed provider, but the vast majority do not. And then the presence of post-exertional malaise, which is a cardinal symptom of many infection-associated chronic conditions and illnesses, should be a factor that governs the initial planning of your entire care plan. So if a patient comes to you either virtually or in person. And again, if we go back to the LIFT acronym and we talk about investigating symptoms, and we identify that someone has post-exertional malaise, what are we going to do? What are we going to do after we identify that they have post-exertional malaise? Anyone? We're going to measure it. We're going to measure it, yeah? Using the DePaul symptom questionnaire or any other post-exertional malaise screening technique that allows us to measure post-exertional malaise. If it's quite severe, what we want to do is make sure that we are planning treatment around the post-exertional malaise severity. So if that means that we need to arrange for care to be virtual, if that means that we need to create a situation where maybe a health advocate is sitting in on some of the appointments and reporting for the patient, and we're working through a third party, or if that means that someone, yes, they can only Zoom in, and maybe they need to be laying down, and maybe they don't want to have the camera on while they're doing that. These are some of the accommodations that you should be prepared to make sure that you don't crash your patient when they're having an appointment. Also, before clinical care begins, you'll excuse the sort of stock image here. I also, wasn't allowed to use real images from published studies, but here we are. Self-monitoring and app-assisted pacing for people who are experiencing post-exertional malaise can be incredibly beneficial. So we actually published 2 papers on this last year. Well, actually, one just got published just a few days ago in Nature Digital Health. But they were the largest studies of their kind, where we had over 4,200 patients who had contributed at least 200 days worth of data, where we looked at the use of app-assisted pacing, which utilized both self-report, so patients telling us, like, this is how I'm feeling today, this is what symptoms are bad, these are what symptoms are good, and also app-based biometrics, so that we were getting heart rate variability, and respiratory rate. So by using an app-based system to guide pacing, we were actually able to see, we saw that 77% of the 4,200 reported improvements in symptoms. We saw that 85% reported improved control of their symptoms, of their illness, sorry. 94% reported better energy budgeting. So they felt like they could better understand how much energy they can use before they're going to crash. And the biometrics, this was in the Nature Digital Medicine paper that was just published, the biometrics allowed us to really enhance our ability to predict crashes and to guide pacing recommendations through the app. So this really shows us again that that post-exertional malaise and adverse events related to exertion are highly physiological and can be predicted by tracking the patient's biometrics. And then on top of that, very usefully, we can use those data to then say to someone, hey, it looks like you're headed for a bad day. Why don't you prepare for it? So why don't you get electrolytes by your bedside? Why don't you prepare for, cancel meetings, prepare for a day where you're going to be mostly horizontal or bedbound, et cetera, et cetera. These preparations can be the difference between being crashed for a couple of weeks versus being crashed for a couple of days. And so it's really important before we start active treatment to think about ways that we can mitigate severe outcomes. So then, as we move into treatment, there's a few just key principles here that we think about. And I think that when we're successfully treating infection-associated chronic conditions and illnesses, we need approaches that are multidisciplinary. We need approaches that are well coordinated. So meaning that the multidisciplinary team are actually talking to one another, imagine that, and having conversations about patients and having conversations about collaborative care. We need often a good care navigator. So, you know, when you tell somebody who has a cardinal symptom of exertion makes their symptoms worse, including cognitive exertion, including emotional exertion, that, hey, here's 1,000 appointments that I need you to book, and you've only got a few days to do it, otherwise the referral is going to go up in smoke, and you'll have to come back to me for another referral, and here's a bunch of other stressful paperwork and things to do so that insurance will pay for your appointments, etc. That's kind of harsh to put on someone. And so making sure that we've got care navigators in place, which, by the way, is a model of care for traumatic brain injury care. So like this is what most traumatic brain injury clinics do. So it is not without precedent. And understanding that roughly 70% of people with infection-associated chronic conditions and illnesses will report having at least mild cognitive impairment as a part of their symptom profile, it makes sense that we have care navigators to help them find their way. So now I'm just going to take you through a really detailed workflow of how we think about care at the core clinic, the Cohen Center for Recovery from Complex Chronic Illness. Again, this is how we do things. We're always open to feedback. Again, this is an idealized version of how we do things, so I'll be the first to admit things are not always perfect, and we're always in a process of continual improvement. But let's start from the top. So a patient emails us, calls us, reaches out to the clinic, and a medical secretary will schedule an appointment. So what happens immediately is we try to have a commitment to have someone reaching out within 72 hours to that request. So even if it is, we're experiencing a lot of emails right now, we're going to get back, you're in queue, we're going to get back to you soon. We just try to make sure that there is some level of communication happening within 72 hours of a reach out. We also, make sure that folks are set up with patient-reported output. So then the medical secretary will sort of set them up with an appointment and say, okay, we want to get a sense of where your symptoms are and what symptoms you're experiencing. So we set them up with patient-reported outcomes, et cetera, so that we can get a sense of where they are, so that the provider doing the initial intake can know the severity and the main symptoms of the patient as they walk in the room, so that we can be somewhat efficient with the intake as soon as they come in. Why is it important to be efficient? It's important to be efficient because we're an insurance-based clinic, which means that what we get reimbursed for in the clinic is roughly a 45-minute intake and a 15-minute follow-up. Now, none of our appointments are that short, so don't stress. But unless you curate a cash pay model, which we don't want to do, because I think probably everyone in this room has seen some of the cash pay models that are out there and what they cost, and that's fine and all, but that's not really helping the majority of Americans who are living with these illnesses. What we need to try and do is get as close to those numbers as possible, or, of course, and which we're doing in parallel, go to Washington and say, hey, can you give us special codes, or can you give us, the ability to extend the amount of time that providers spend on intake and follow-up for these illnesses. So once the schedule has been set, we then move into the sort of, the baseline assessment. I think I just mentioned this. We use a platform called REDCap because it's free and, it's HIPAA compliant. But we basically just send out a whole bunch of patient-reported outcomes, and we automatically score them for the provider so that the provider can see these are the symptoms that are most problematic, these are how severe they are, and that way the provider can really target their initial intake. So then we move into the initial intake. So this is done by a nurse practitioner or an MD. And again, we bill it through insurance. We discuss the PRO results with the patient. Based on some of the symptoms that are being reported, the provider will then send out for different specialty assessments, things like autonomic testing, things like metabolic testing, and also a myriad of blood tests. Again, the blood testing is decided based on the symptoms. So we go where the symptoms and what the patient is telling us lead us. Once that initial sort of initial appointment has happened, we start to begin initial treatment recommendations. So, we set people up with PT, we send them out for comprehensive physical assessment, we send them out for blood tests, we look for mold, we do all of the things that we think might be driving symptoms in these patients, and that allows us to better understand, the clinical picture that we're facing. And sorry, everyone, I'm not used to not having a computer right here. It's causing a few problems. I think it's also important to name that we're always working on adjunct clinical services as well. So adjunct services can include sending nurses to a patient's home for IV infusions, saline infusions, glutathione infusions, other infusions that can be incredibly helpful to patients. Something as simple as saline can make such a difference for so many of our patients with severe POTS. Many of our patients will call them rescue fluids. They go from being completely bedbound to being able to walk around for a few days just with a simple, normal saline infusion. It's also why, just in case anyone's interested, we hate clinical trials that involve infused drugs that use normal saline as a placebo, because it can be so effective at improving people's symptoms when they have POTS. So something as simple as setting someone up with home infusions can be a complete game changer to their symptoms. We set folks up with social work so that they can have access to group therapy, where they can meet other people who have similar complex chronic illnesses, similar challenges, live in the same neighborhood, so that they can chore share, they can be friends with one another, and they can experience a little bit of social support in an illness that is incredibly socially isolating. Because loneliness does not help complex chronic illness. Loneliness puts strain on the immune system just all on its own. So we want people to have social prescription and social connection. In addition, our social worker just does general casework, helps with disability management, and helps to sort of just make sure that our patients get what they need. And also our social groups also include the caregivers of people with complex chronic illness. So we run group programs for caregivers as well, because that can be a tough space to be in, especially when you're brand new to the world and it's not been your reality for a few years and you didn't see this coming. We also have health coaches who are incredibly helpful to our patients. CMS actually recently released a couple of new health coaching codes that allow us to bill insurance for health coaching. Another thing for the clinicians in the room that is sometimes really, really helpful to get health coaching paid for through insurance is if your health coaches, and our health coaches are, if your health coaches have a professional degree, so registered nurses, physical therapists, occupational therapists, etc., they can also build complex care management codes for many of our patients, because for complex care management, all you need is a couple of chronic health diagnoses, which most of our patients have, and then CCM codes become available as well. So if you're struggling to bill the health coaching codes, which are quite new and sometimes insurers push back on, you can bill the CCM codes, and those are old as time, and insurers actually don't push back on them so long as you say, look, this person has uncontrolled POTS and uncontrolled diabetes, so we need them to have a health coach, and we're going to bill the CCM codes. In addition to all of the PROs and the sort of clinical intake, we do objective physical assessments. So something that we're rapidly publishing on that I think is just really important to think about is we are always told that people with infection-associated chronic conditions and illnesses don't have biomarkers, and yet it has been published multiple times that over 70% of people with IACCIs will meet diagnostic criteria, American Autonomic Society diagnostic criteria for POTS and other dysautonomias. And so we can test for that using the active stand test. Again, if you don't have a lot of equipment, you can test with the active stand test or a tilt table test if you do have a tilt table. And these give you objective outcomes. They show blood pressure either shooting up into very scary areas or dropping down into very scary areas. They show heart rate changing and fluctuating. We see changes in skin. We see symptom reporting that allow us to make an objective diagnosis. Similarly, we see metabolic dysfunction. So we use resting metabolic rate as a proxy for mitochondrial dysfunction. And we've seen that, again, around 60 to 70% of people with long COVID have sit in a hypermetabolic state when we measure the resting metabolic rate. Hypermobility assessment is crucial. So our clinic employs physical therapists who are experienced with hypermobility spectrum disorders. Many of our patients experience joint hypermobility, and this can be measured using things like the Bateman score. So all of these things allow us to, and then with cognitive assessment, in addition to doing pen and paper cognitive assessments with neuropsych, we can also do quantitative EEG assessments, which really allow us to see how the brain is responding to stimuli where it's very clear if the electrical response of the brain is diminished or hyper-reflexive to certain well-established EEG paradigms. I've been given the sort of the hurry up, so I'm just going to finish up with the final few slides, but just to point out, once all of these assessments are done, then begins the cycle of following up with the MD, trying out new things, doing new tests, treating with new medications if the old medications aren't working the way that we would hope, reassessing, reevaluating, rinse and repeat. So just really continuing to try and narrow down what's going on and continuing to support our patients as they go. And really as objective as one can be with these dynamic illnesses to really understand how were you doing a month ago, how are you doing now, with numbers, not just with this subjective, tell me how you're doing, and someone's like, I don't know, maybe I'm better, maybe I'm not better. Again, and this is where using the app-based systems can be really helpful, where you can actually say, oh, well, let's look at I'm not allowed to name the app, but let's look at your app. And, oh, it looks like you had 50% less crashes this month. Maybe we're doing something right because this change in your physiology seems to coincide with when we started the low-dose naltrexone. So these are the ways that we can start to understand the physiology of these illnesses. So I'll finish off with just a few things on my wish list for what we need right now from the research and the clinical world. We need providers to understand that this is not a monotherapeutic problem. If there was a silver bullet that solved these issues, we wouldn't be sitting in this room on a Saturday. It would be done. We'd be finished. These are complex chronic illnesses. We need multi-therapeutic approaches. We need combination therapies that sometimes even the timing of when you apply the combination therapy really, really matters. So we need much more complex much more complex treatments to be able to give our patients answers. And we need to borrow from models that already exist. Oncology does this really, really well. And they went through their own sort of biopsychosocial model of oncology. They went from, the 80s being told you got colon cancer because of your cancer personality. I'm not making that up. That's documented fact. Now we're in 2026, and if you get cancer, they say we're going to give you this medication because of your genetics and because of the genetic sequencing of your tumor and because of all of the other medications that you're on. That's the level of complexity that we need. We need more intelligent phenotyping of patients. We can't keep lumping people together. We need to start splitting. We need to start saying, you have long COVID, but you have the autoimmune version of long COVID. You have long COVID, you have the persistence version of long COVID. You have long COVID, and it's POTS and dysautonomia. We need better phenotyping, and that also includes next generation testing for pathogens and sequencing of tissue. And we need to learn from everyone out there. So, one of the things that we do a lot at the core is we just put our ear to the ground and we talk to our patients and we say what's working. Especially our patients who we have failed to treat over and over again, and then they come back and see us and they're like, I'm doing much better. Okay, what did you try? Tell us, You tell us what you tried, and then we will dig into it. That level of bidirectional innovation is crucial in this space, and I can't say it enough. It's been missing from the field for the last 40 years, and we need to bring it in, because a lot of the time, some of the most effective interventions that we have seen in our clinic have come from patients that we failed on, coming back to us and saying, you should really look into this intervention because it made all the difference for us. And then we apply the intervention and it really helps. So these are the sorts of things that we need to keep in mind. And then God, we've got to move fast. People have waited for long enough. My biggest trigger is a lack of urgency. This is also why I came in pretty hot about the CME accreditation thing, because they were like, in 10 years, your slides can look much different, it'll be fine. I'm like, guys, we've got to move faster than 10 years. So we've got to move faster for a lot of reasons, not least of which because people can't afford off-label, out-of-pocket treatments, and we've got to do better. So I'm just going to end with all of these acknowledgements of the wonderful people who actually do the work while I'm in beautiful Santa Barbara talking about it. And anyone got any questions?
We actually, Dr. Petrino, we are going to open it up for some questions now.
Yeah.
We have questions from the chat.
Oh.
I'd like to lead with that. And then anyone, if you do have a question, please raise your hand. I will bring the microphone to you. But for the first question, let's lead this off. We don't want to neglect our web viewers. Now, there seems to be some overlap between long COVID and connective tissue dysfunction and autoimmune conditions. Can you speak to what you're seeing directly, clinically, in terms of how these interact and what treatments seem promising?
Yeah, absolutely. It's a great question, and this is right back to some of the work that we need is to better understand what we're looking at when we're looking at a single diagnosis. So many people with long COVID experience hypermobile joints, and what we might say is, a hypermobility spectrum disorder. Now, one of the things that we know is that a ton of people with long COVID also have mast cell activation syndrome, MCAS. Histamine, when histamine and other inflammatory chemicals are sort of circulating through our bodies long term, this can lead to joint laxity. It can lead to collagen breakdown. It can lead to all sorts of, severe issues with joint hypermobility. And by contrast to that, so that can be one driver of joint hypermobility and connective tissue issues. On the other side of that, we also need to think about pathogens. So, Mickey Tal, who's a researcher at MIT, just published some really interesting work in a mouse model of Borrelia infection, where she showed that when mice get infected with Borrelia, which is the bacteria that causes Lyme disease, she actually showed that once the infection passes from acute to chronic, Borrelia starts to burrow into tissue. What tissue does it burrow into? It burrows into collagen. And what happened to the mice? They started to develop hypermobile joints. So in addition to the fact that, some of the chronic inflammation can cause joint hypermobility, also certain pathogens can cause joint hypermobility by virtue of the fact that they hide in the tissue and cause that tissue to become weak and lax. So understanding that overlap, I think also will start to come as we understand these drivers that we've mentioned, in this case, reactivated pathogens and chronic inflammation a little bit better.
All right, thanks. And now I have a question from the field here.
Thank you. My name is Carl Sanden. I'm a physiatrist. My clinical work is in trauma rehabilitation. I'm on a faculty at Creighton, but I also do a lot of disability policy as the chief clinical officer in Washington, D.C. for the Medical Rehabilitation Trade Group. So I work at Function Medicine coming together with disability policy. Social Security notoriously dislikes syndromic diagnoses as it adjudicates medical records for disability for long-term disability benefits. What is the current state of federal concurrence with requests for long-term disability benefits due to long COVID? And are there specific recommendations that I can take back to clinic or other physicians can take back to clinic to include in our medical records that are more likely to result in success when we help patients apply?
Yeah, super important question. Thank you for it. I would say that the current administration has said that they're here to support long COVID and infection-associated chronic conditions and illnesses, and Secretary Kennedy and HHS have made a lot of fanfare and a lot of noise about the fact that they believe folks with long COVID and they believe folks with chronic tick and vector-borne illness and ME/CFS. And so I have not seen any discernible change to the policy that these are recognized conditions under the ADA and that they can be, they can be used to apply for long-term disability. In our clinic, we actually do have a pretty high hit rate with not getting knocked back. And what I can say is it comes down to what I was saying earlier, which is when we describe a symptom profile in terms of, well, they scored this on the EQ5D5L, they scored this on the fatigue severity scale, they scored that on the DePaul symptom questionnaire, and we, in our letters, and actually in the manual that we have on the hhs.gov website, we actually have templates of the letters. We use references, and we say, like, this is something that has been seen in this condition, it's been reported in this condition, and this is where they're scoring. We also, use their autonomic testing results. So, hey, their blood pressure changed by 30 millimeters of mercury. That is American Autonomic Society standard for POTS. So all of that is to say the best advice I can give is being as concrete and objective with the subjective reporting, as well as when you do physical testing, leading with the physical testing and saying, well, we're seeing physiological changes, and even regardless of if you're someone reading this for, if you're a decision maker at, a Social Security Administration and you don't believe in long COVID, if a person is still hitting American Autonomic Society criteria for POTS, you got to believe in POTS, and And there are concrete numbers, and we're providing the concrete numbers. So, so I don't know if that answers the question fully, but that's how we've been approaching it, is as many numbers as we can throw at them and as many references that we can throw at them. And we rarely get knocked back. It does take a lot of time, though. Writing those letters are like 3 hours, and I've heard that elsewhere patients pay up to like $1,500 for a letter, which is crazy.
Got another question from the audience right here, Dr.
Yeah.
Petrino.
Hi there. So, a few questions and thoughts. One, is there a couple of treatments you're thinking, wow, besides treatment for POTS, I wish primary care doctors knew about this novel treatment. That would be really helpful. And also, how often do you test for those chronic diseases that you say may be reemerging? And thirdly, how do you self-monitor? I mean, is it with a particular app? Do you have people just do an automated blood pressure cuff at home? Because it looked like on the slide it was some fancy thing that my watch doesn't have.
Yeah. Yeah, so now that the CME accredited portion of the the meeting is over, I can tell you all of this stuff. Thank you for all the questions. So the app that had the outcomes that we were talking about in the 2 publications that are now out in the world is an app called Visible. And for our patients, we have no affiliation with the company other than that we do research with them. They don't pay us, they don't, but, it really does help patients to understand their symptoms and to pace and to manage things. There is a free version of Visible where you can just download the app, you can enter in data, and it can actually monitor your heart rate and your heart rate variability by using optical sensing on your smartphone, where you just pop your finger over the camera and it counts your heart rate and it counts the time between beats, so you get heart rate and heart rate variability. You can also have a paid version of the app where you actually have a wearable that sits on the upper arm and does heart rate variability, as well as SpO2 and respiratory rate. So that's the app that we recommend to most of our patients. There are other apps out there. A notable one that a lot of our hypermobile EDS patients like is called Guava. The reporting burden on Guava is a lot more, so it asks for a lot more details. So some folks with exertional intolerances don't like that as much, but some folks with hypermobility spectrum disorders who want to really dig into some of their symptoms do really enjoy it. So it really is dealer's choice there. But those are some of the apps that we use. In terms of some of the treatments beyond POTS interventions, we are really excited about immunotherapies. So, things like low-dose rapamycin in patients who are showing signs of T-cell exhaustion and immune dysregulation often will benefit strongly from low-dose rapamycin. Of course, again, this is always, you've got to make sure that your kidney function is fine, your liver function is fine, you've got to make sure that your cholesterol is in a good place. But low-dose rapamycin is one that we're seeing good results with. We also have we published work on a case series, which we're now about to move into a randomized controlled trial of combination antivirals, where we actually combined Valtrex, Celebrex, and Paxlovid together in a 120-day protocol. The Paxlovid is only taken for 15 days, but the other 2 drugs are taken for 120 days. And we saw almost all of our patients experience significant remission from symptoms. So no one danced out of the trial saying like, I'm cured, but everyone said that it made a meaningful difference on their symptoms. And at 700-day follow-up, 600-day follow-up from stopping the protocol, those gains had persisted. So at that point, we were also fairly happy that we weren't looking at a placebo effect, even though it was an open label trial. Now we're moving into a placebo-controlled trial for that particular drug combination. finally, one of the more exciting trials that we've just completed, which we're just moving into, we should have a preprint up early next week, is there's a technology called microtesla magnetic therapy, which basically uses low energy magnetic stimulation over the head with the goal of reducing neuroinflammation. The way that it reduces neuroinflammation is by a process called mitohormesis. So it stresses mitochondria just enough to cause a antioxidant cycle in the brain. This had been validated in animal models, and we did the first in human trial. It was a triple-blind, placebo-controlled trial where we saw significant improvements in cognition in the active treatment group that not only persisted 4 weeks after the therapy was stopped, but actually continued to improve 4 weeks after the therapy was stopped. So these are some really exciting treatments that we're hoping to get out ASAP. And I could go on forever, but maybe catch me after the after the talks.
I've got another question for you. Rapid fire.
Okay.
Thank you, Dr. Petrino. Full disclosure, my name is Easter Mormon. I'm married to this guy. Thank you, Chelsea, for bringing this conference to town again. So I work for VNA Health. My role is in basically communications. I'm the PIO, but I'm a data junkie at heart. And you mentioned a number of portals where we collect information. And I am just curious what role AI has in solving all this through data integration. Do you have a partner? Are we working towards that? Because I'm curious if we can find a root cause analysis, we might be able to actually make some significant headway.
Yeah. I think that the short answer is yes, absolutely. The longer answer is we need to be incredibly curated about the data that are being collected. So, for instance, there's a company called Rhythm, RTHM, that provide long COVID services to people remotely, so via app. And they're incredibly intentional about their data capture in a way that is very infection-associated chronic condition and illness informed, which I really love. And it's data sets like that that I think are going to be really important for training AI on how to identify potential treatment targets and help pathways a little bit more. But I do think AI does have a legitimate role, and actually I would even say that right now AI is better than the majority of providers in the world at identifying IACCIs. If you speak to most long COVID patients who on their own self-determined that maybe I should try famotidine, which is Pepcid, as a treatment for their cognitive impairment, most of them will tell you that TikTok found it for them. They were sort of just swiping up, and then some chronic sickness, illness influencer said, this was the game-changing thing for me, and then they try Pepcid, and then they're better. So already we have AI that is guiding people to answers much more efficiently and much more effectively than providers, which is a sad state. We need to do much, much better than that, because that's not safe, but it is the current reality.
We're going to take a couple more questions from here, and then we're going to close out with the question from the chat. Right here, sir.
Thanks for the presentation. Have you encountered patients who contracted COVID? They were ill for a week, maybe 10 days, recovered, seemed to feel better, but then several years down the road, say 2, 3, maybe 4 years, they begin to manifest long COVID symptoms?
Yes, absolutely. I think that right that beginning slide, where we were talking, it feels like we barely knew each other back then. But right back then, we do see that a lot. And actually, we just released a paper where we show that we did gut biopsies in a number of people who had long COVID and a number of people who were healthy controls. And what was interesting was we were looking for spike protein, and in a subset of the healthy controls, we saw spike protein sort of hanging out in their colon, hanging out in their ileum. And what was interesting was it was there, it was persisting, but when we did something called spatial transcriptomics to look at whether it was interacting with the tissue around it, it wasn't. Whereas in the long COVID patients, it was causing all sorts of pro-inflammatory protein release, oncogenic protein release. It was causing problems. And one of the things that we think, that little result haunts me, because I do think about that as like, okay, well, what is that thing waiting for to sort of pop off in the healthy controls? Is it one more flu infection? Is it one more sort of upset stomach from norovirus or food poisoning? What could cause that thing to start becoming a problem where it wasn't a problem before? And so that's why, personally speaking, I'm starting to get a little bit bullish on the idea of monoclonal antibodies and the idea that maybe everyone should try a dose of monoclonal antibodies to just clear some of this sort of antigen that could be persisting in our systems, because it's something I worry about.
One more question right here.
Hi, I'm Penny Bornstein. I'm the Director of Public Health in San Luis Obispo County, and I've been out of the clinical arena for quite some time as a preventive medicine doc. My question has to do with, has long COVID and the relative acceptance of it in the primary care community led to more acceptance of other chronic conditions like fibromyalgia, chronic Lyme, CFS, et cetera? Because I'm remembering not that long ago when clinicians were pretty dismissive.
Yeah, I would love to hand that question over to sort of like someone who actually studies it, as opposed to someone who lives in the sort of echo chamber that I live in. I've been very fortunate in the fact that Mount Sinai has been supportive of the work that I do, and we've been able to include it in the medical curriculum at Mount Sinai so that first-year students get access to this sort of information. And we do bring up all of these other infection-associated chronic conditions and illnesses. And what I can say from that experience is that the young incoming providers, or potential providers, are very accepting of the information, and they don't question it at all. They say, wow, this is really interesting and this is a whole new area, and they accept the information without bias. I also think that from doing other educational events like this, we can see that education is extraordinarily important in changing people's minds of providers who have been treating for a long time, and maybe will come into a room like this not convinced about the legitimacy of these diagnoses and come out saying, oh, well, maybe I was wrong about that because there's all of these good publications. So I can say that education helps, and at face value, young learners are taking it without question. The extent to which this is happening nationwide, I can't be as convinced of, but I hope that it is happening.
We can take one more question from the crowd here, if there are any attendees here that have a question. No, really. I'll go over here. Give me one moment. Don't all raise your hands at once.
Hey, I'm a parent of a 12-year-old child who has CFS, and building off the last question, we've encountered a lot of skepticism from many providers. And I'm wondering if you have advice about trying to find providers who, whatever knowledge they may or may not have, are open to working with you to implement solutions that you've found on TikTok or wherever else.
Yeah, I mean, I would say probably the most useful advice I can give is jumping on the websites of advocacy organizations, groups like Patient-Led, groups like Solve ME, other groups that actually, Dysautonomia International, that pull together maps of providers who are informed, who can sort of help you find someone in your neighborhood, because I do understand that it's incredibly difficult. It's, for how hard it is in adults, it's 5 times as hard in kids. So I mean, I commend you for, and I'm sorry for what you're going through. Our clinic does not yet see peds, even though some of our providers are willing to see some of the younger patients, and in some cases we've even, there's an Italian long COVID doctor named Danilo Buonsenso, and he gives me his email. He's like, look, I'll have a conversation with someone. He's like, I don't mind doing that, but that's a really terrible solution for someone living in California, just the time zones alone, right? But so we need much better care.
Protect that father and child at all costs. We got one more question right here.
Hi, Dr. Pacino. I'm myself a long COVID patient, and thank you for everything you do and for everyone here. But where exactly are things, from what you understand, in preventing long COVID from acute COVID infections? 10 to 30%, as I understand, of infections lead to long COVID, and then you have to deal with everything that's being discussed here. Are there any breakthroughs there, or things you're looking forward to on that front?
Yeah, absolutely. Thanks for the question, and thanks for coming. I said it before, I'll say it again, I'm really bullish on monoclonal antibodies. Invivyd has a new monoclonal coming out, VYD2311. Again, I don't work for the company, I'm just a fan, an enthusiast. But, the vaccines do not prevent COVID. And I want people to have as many tools in their tool belt as possible, and vaccines are important for reducing severity of acute infection, but they don't prevent COVID, and we have shown over and over and over again that severity of initial acute infection doesn't map onto your chances of getting long COVID or not, at all, in fact. Ziad Al-Ali published one paper indicating that maybe it did, and in the end, he was kind of like, actually, I was wrong about that. It was just the fact that many of the severe acute patients were overrepresented in his population, which was the VA data. So it was just older people who got less sick because of the vaccine. And he's gone ahead and said, actually, that was not correct. So we need better strategies. And so I'm really excited about Invivyd. I've seen some of their preliminary data on preventing infection post-exposure, and it is really strong. So it is really pretty much, if you get that, monoclonal injection after you've been exposed, you're not getting COVID, which that's the sort of thing that we need. Also, Shionogi has a new antiviral coming out with similarly strong post-exposure prophylaxis data. So I think they showed something like a 94% reduction in after household exposure in COVID infections. So last I heard, they've released the results of that study, and last I heard that they're looking for FDA approval for post-exposure prophylaxis by June of this year. So these are some of the things that, because I think that as much as we want to continue treating long COVID, if we can wipe out what causes long COVID, which is getting COVID infections, that's one step in the right direction as well. Yeah.
And with that, folks, we are going to conclude this incredible Q&A session with Dr. Petrino.
Thank you.
We're now going to take a short break, about a 15-minute break. We're going to have some food items. So please stand up, stretch, go get some air, and we will be back. Thank you all for attending. And what a great conversation. And we're about to resume our program in just a couple of moments here, folks. For our attendees who are viewing online, thank you for the intermission with us. We're going to be having our physicians panel that's moderated by Dr. Hamami, and there are going to be time to ask questions during this panel. So we are about to conduct the physicians panel with Dr. Hamami, and there will be a Q&A session at the conclusion of the panel. So please make your way back in and grab your seats. We're about to get going as I'm about to welcome Dr. Hamami back to the stage. Okay, ladies and gentlemen, as you can see, Dr. Hamami is up on stage. I'm about to relinquish my microphone, but I would like to welcome you all back, and we will now have our physicians panel moderated by Dr. Hamami. Thank you, Dr. Hamami.
Thank you, David, and welcome back, everybody. It's an honor to be moderating this session with our panelists. Let me briefly introduce each one of our esteemed panelists. Of course, if I have to tell you about each one of them, that will take probably a full day. So joining us virtually, we have Dr. Linda Geng. Dr. Geng is the co-director at Stanford Long COVID Collaborative. She has also served as the director at Stanford Consultative Medicine Clinic. She's a clinical associate professor at medicine and primary care and population health. She is board certified in internal medicine and was a visiting scholar at the NIH for undiagnosed disease programs. She completed her residency in internal medicine at Stanford University and received her medical education from the University of Washington School of Medicine in Washington State. She also received her PhD at the University of Washington in molecular and cellular biology. Her clinical focus is on long COVID and post-infectious syndromes, complex and puzzling conditions, undiagnosed diseases, and medical mysteries, rare disorders, in addition to diagnostic medicine. Dr. Caitlin McCauley is a clinical assistant professor at Keck DTLA and COVID Recovery Clinic at the Department of Family Medicine and USC. She received her Doctor of Osteopathic Medicine degree at Touro University College of Osteopathic Medicine and completed her residency in family medicine at Chino Valley Medical Center. She has a broad range of interests in family medicine, including musculoskeletal medicine and osteopathic manipulative treatments, mental health, sleep, HIV, PrEP, gender-affirming care, preventive medicine, routine women's health, and routine diabetes care. She believes in treating every person as a whole, composed of mind, body, and spirit, regardless of their background, gender, identity, race, and ethnicity. She is available for in-person and telemedicine visits. Dr. McCauley has also been caring for patients at the Keck COVID Recovery Clinic since December of 2020. And Dr. Nisha Viswanathan is a primary care and extensivist physician who practices in Santa Monica and Westwood. She works with medically complex patients and coordinates their care between the inpatient hospital setting and the outpatient clinic setting. She is co-director of the UCLA Health COVID-19 Ambulatory Monitoring Program and director of the UCLA Long COVID Program. She is a fellow in the American College of Physicians and is board certified in internal medicine. She received her medical degree from the University of Arkansas in medical sciences. She then completed her internal medicine residency at Mount Sinai Hospital in New York City. She is a clinical instructor at the David Given School of Medicine at UCLA and is involved in resident education. She also researches gender-based differences in the medical profession, such as barriers that keep women from reaching leadership positions and why female physicians are promoted at a lower rate. Thank you all for being here. We have few questions, but then we will probably take 15 minutes for questions from the audience. This is going to be more an interactive dialogue, so I might be asking one of you a question. However, the others can definitely chime in. So let's start with Dr. Geng, and if we can start with what aspects of, we just heard from Dr. Pawson the importance of understanding patients and especially those patients that keep bouncing back and forth between physicians. So what aspects of long COVID remain most misunderstood or underestimated by clinicians?
Yeah, thank you so much. I hope everyone can hear me. And I just want to also first begin to say it's such a great privilege to be on this panel and to be able to participate. So thank you for the organizers for running this really important forum, and to all the colleagues and the patients who are all part of this collective village tackling this important problem. So I think the question about, what is the one area that I wish if I could make the biggest change right now in terms of clinical care in the community. And this is one of the biggest aspects that we're focusing on right now as part of our AHRQ funded long COVID care REACH initiative, which is resources, education to advance community health. When we go out to the community, especially for primary care, and that is my home in internal medicine, when I talk to other PCPs, one of the biggest issues is that it's not being recognized. And this comes from a lot of different reasons. One is the stigma associated with this condition, and we need to change that. Long COVID is a real disease. Of course, I'm a little bit preaching to the choir at this forum, but I think it's important that we make that really well known in medicine and to our colleagues in the profession, not just within our echo chamber, but beyond, especially in primary care, where Dr. Parson was saying that's usually in the front lines of where patients initially go to. But when we did we've been doing essentially a roadshow of tours and talking to clinicians on the ground and asking them, how many patients are you seeing who have long COVID? And some clinics that we go to say, and they have thousands and thousands of patients, have zero. And so that is a really stark and concerning finding. And to me, that speaks to the fact that we really need to improve education from the trainees to senior practitioners, interdisciplinary wise, from nurses to all the staff members. We need to raise awareness, and also community health providers and community health advocates, as well as community health workers, and particularly marginalized communities. So I think that's huge. And then two, the stigma that surrounds it. We also heard during our partnerships and communications with clinics and clinicians, there's still a significant belief out there, which is incorrect, that this is a psychogenic or psychological illness. And unfortunately, because of the uninformed and under education and training and support for primary care, as well as other community clinicians, there's both a lack of resources, knowledge, training, and then the stigma that surrounds the condition that presents barriers for people to even be recognized and diagnosed. So I think, to me, we can't treat without first diagnosis. And Dr. Petrino did an amazing presentation talking about the different aspects of diagnosis. But I think recognition is really important, and being able to provide the tools and resources to very busy primary care clinicians to be able to identify the patients is a really a big priority.
Thank you. Anything to add?
Yeah, I mean, I could jump off of the idea of I wish we had better tools, better screening tools, better questionnaires that we could give in the primary care clinic. Yes, I'm family medicine, and so I have created in my own medical record system. I have created my own dot phrases or auto phrases that have the ME/CFS criteria, right? That have key points to talk about when we're talking about post-exertional malaise. But that, again, I had to create that. That is not an easy tool that I could just hand over to a patient. In the moment, I know about it, and so it's about trying to get that as something easier for just regular primary care.
Yeah, just echoing these same sentiments. Long COVID, the understanding of it, education around it, and I think actually community awareness is a big portion of this. Patients have to be able to advocate for themselves, and I think someone brought up AI earlier, and it has been proving to be a tool that has allowed patients to start to recognize that what their own symptoms may be and be able to bring that to their clinicians to try to get the care that they do need. So I do see promising signs that we will have progress, even if it comes in fits and starts sometimes, but that both technology and increased community and education of providers will get us there.
Thank you. Dr. McCauley, we heard a lot emphasis on understanding the patients and also listening to them and investigating to reach a diagnosis. So, which diagnostic strategy do you usually stay away from, or are you moving away from?
Well, I know in the beginning we saw a lot more use of things like CT chest, right? For instance, our understanding, and this is really calling out very specifically the shortness of breath that can happen in cases with long COVID. What I typically do is, yes, if there has been, the symptom has not been investigated, we do need to do a chest x-ray if it's been going on for longer than a month. But it really is my first sign to start thinking about POTS. And so it really starts me to think towards autonomic testing. So I'd say instead of going down extensive pulmonary workups, we typically are moving away from that at my clinic.
Any other thoughts from our other panelists?
I would say that also maybe now that we know more about the timelines around long COVID, it has made it a lot easier to also understand patients' various symptoms and be able to validate them in a more cohesive manner. And I say this because, you know, in 2020, 2021, we were really fixated on if you had COVID, what were these symptoms? What was the timeline the symptoms are happening? It must not be long COVID if it didn't happen in those first 6 months after your infection. And as we've learned more, it has helped me understand that, not just me, but I would say a lot of the providers who do this work, that really it waxes and wanes. We may never know if you had a COVID infection, and that doesn't take away that you are experiencing these symptoms and the lived experience of those who are experiencing them. And so I think that is really one of the big things as the takeaway is that patients who are experiencing ME/CFS or POTS or MCAS, and without having that COVID infection necessarily documented, does not take away that they have long COVID. And being able to label it really does provide a place for so many patients to feel like they have something to anchor to and work towards their recovery.
Great, thank you. Dr. Gang?
Yeah, thank you. I'd like to also go back to what Dr. Petrino said earlier about subclassification and the importance of understanding that long COVID is an umbrella term and that there are many diagnosable conditions under that umbrella, because I still think this is a point of confusion. And even as the definition evolved, initially what was being considered during the NASM workshops was that long COVID could be a diagnosis of exclusion, which means that if you work up, a patient's fatigue and you found that it's due to a thyroid issue that's diagnosable, or due to a rheumatologic new autoimmune disease or sleep apnea, that then it's not long COVID. And I think this is a thing that we have shifted away from in the field, and to recognize that you can have long COVID and sleep apnea that was new onset, triggered or worsened by COVID. So it's the understanding that COVID can both exacerbate and worsen a pre-existing condition, and then also that COVID can trigger and bring on new conditions that are independently also diagnosable and co-occurring.
Thank you. We also heard that these are complex cases, and sometimes they manifest in a variety of symptoms and different cases and different between patients. They're different. So starting, I think it's important to understand from each one of you, but starting with Dr. Viswanathan, which of the pharmacologic or non-pharmacologic strategies have you found helpful?
So I think it's very dependent on which syndromes coexist in our patients with long COVID. And so maybe here I'll just break it down by symptom cluster and what I've found to be strategies that are successful. In my personal experience, the more recent variants of COVID have led to substantially higher rates of POTS and dysautonomia. And so evaluating for those conditions has not only become imperative, but treating them accordingly is of equal importance. And this is really focusing especially on those cardiac medications. But really in my clinical experience, I have found that really ivabradine has probably been one of the most successful medications in managing POTS and dysautonomia. It's been really tough to get it covered by insurance, but I have found that if you have a diagnosis of inappropriate sinus tachycardia, sometimes you can get the coverage. But very, very recently, Mark Cuban's Cost Plus Pharmacy started covering it at a rate of $40 a month for patients at cost. And that, to me, has probably been the single biggest thing that I've been able to jump to in terms of treating patients with dysautonomia. It avoids having to have flare-ups of their mast cell activation because we gave them a beta blocker. It avoids any of the challenges of blood pressure that come with anything else that is a beta blocker or a calcium channel blocker, or any of these other agents. And not everyone needs like a fludrocortisone or a midodrine, which can actually carry their own set of side effects for these patients. So some things there for dysautonomia. Simultaneously, what Dr. McCauley said is the shortness of breath to me is always a trigger on the dysautonomia nowadays. So treat the dysautonomia first before you're talking about bronchodilators or doing any further pulmonary workup. In addition, when we're talking about brain fog, a lot of these patients have maybe migraines, are also having concomitant depression and anxiety, and I have had a lot of success in managing these things with either a combination of SSRIs, medications targeting anxiety. Buspar has been really successful in my opinion. Bupropion has been really good to help establish that a lot of patients have ADHD type syndromes and difficulties with concentration. And then we're doing a small trial of memantine over at UCLA, which is a medication that was initially used in Alzheimer's disease, but we're actually seeing it's potentiating the nicotinic receptors, and effectively it is helping with this brain fog, migraines, and many patients are noting improvements with their symptoms. So I would say looking at kind of those big symptom clusters there. And then the last one is fatigue, which I think a lot of people have spoken about low-dose naltrexone as a successful strategy. But for patients who can't tolerate low-dose naltrexone, we've been finding quite a bit of success with low-dose aripiprazole as well. So that is another strategy that we have seen in managing this. But fatigue remains still a more difficult symptom to manage. Truthfully, it's still a lot of pacing and still a lot of energy management strategies. And so I do look forward to, as more clinical trials are coming out, about what could be coming down the pipeline there.
Great, thank you. Dr. McCauley?
Yeah, so I know this is where we're going to be pretty much in alignment on things. The brain fog, fatigue, and nerve pain for low-dose naltrexone. So amantadine is on the American Academy of Physical Medicine and Rehabilitation guidance statement for long COVID treatment. That is a cousin, sister to memantine. I know some of our headache neurologists prefer memantine instead. It's a little more potent. I've seen some success with the fatigue and brain fog with the amantadine. And yeah, I think you did a great job running through the options for dysautonomia and POTS. I think perhaps guanfacine is another that can have some nice crossover for dysautonomia symptoms, as well as potential kind of, again, the concentration focus ADHD type symptoms. Yeah. And then non-pharmacologic I would add in, and I'm sure we'll discuss this more, but and I know Dr. Pacino already hit on it, but occupational therapy, really working on pacing, energy conservation, some of these other tools in the toolbox that are not medication.
Thank you. Dr. Geng, anything to add, and maybe to expand it a little bit more? How do you manage those that are either homebound or bedbound and in severe cases that have limited mobility?
Yeah, thank you so much. And I do want to echo, I think the theme that is coming out here, and Dr. Pacino hit on this as well, is that you really need, first of all, tailored, right? You need to understand what is potentially driving the patient's symptoms and some of the syndromes that overlap, as well as the multidisciplinary approach. Like, for example, our team has over a dozen specialists in various different areas of expertise: autonomic neurology, headache neurology, cardiology, pulmonology. So I think it really needs to draw that multidisciplinary expertise, rehabilitation expertise, occupational and physical therapy, et cetera. And some patients we found too have, for example, developed a lot of sensitivities to medications, either pre-existing or COVID-induced. So that's another consideration. And some actually prefer not to take certain medications because of that, or have, reactions to things that should be noted. And so that's something that we have learned over the years as well. And to your point too about treating patients where they're at, I think this is so important, especially given the severity that patients can experience for being bedbound due to their symptoms, homebound, transportation barriers, as well as in communities that are especially vulnerable and have low resources to be able to, for example, take the transportation or time off work to be able to travel long distances and access typically academic medical center based care. And so that's exactly as part of our initiative from the ARC funded, or about 12 institutions around the country, including some of our colleagues here, Mount Sinai and others. We're trying to develop systems and evaluate models of care where it's not just concentrated expertise at certain places, particularly urban centers and medical centers, but really democratizing that knowledge and expertise and creating networks, partnerships. So that's what we're trying to do with federally qualified healthcare centers, serving communities where they are with providers they trust. That includes things like the, for example, ECHO type model, where this was out of University of Mexico, but you can have experts on teleconferencing who are peer-to-peer mentoring or peer-to-peer supporting primary care docs out in the community serving patients. And then also, I think it's important for clinics like ours to have telemedicine capabilities. And so I think like one of our colleagues have spoken as well about this, is being able to do video visits, telephone visits, and connect with patients where they are. And I think these resources all come together to help improve and expand care.
Following up on that, Dr. Gang, we know that long COVID requires a lot of coordination between different specialties. So what roles are essential in a multidisciplinary model?
Oh, it's really important for that teamwork. That means a multi-specialty within physicians as well as the whole team. That includes support staff, that includes wraparound and also interdisciplinary professions. So we really advocate for, like I said, long COVID, and also Dr. Petrino made this point as well, is that it is really a complex illness. And for any given individual, it may involve multiple organ systems, dozens even. And so we're thinking about not only the medical specialties, for example, cardiology, neurology, et cetera, hematology, gastroenterology. I mean, the list is really quite long, and rheumatology and pain medicine, but also thinking about our other colleagues in pharmacy, and as well as social work and behavioral health as well, to support the impact that long COVID can have on life, on disability, on mental health, and all these other impacts that this significant condition can have. And so it really takes a whole village. And of course, that takes resources. And I think that's really challenging for a lot of clinics to be able to maintain that and to be able to build that network of team members to be able to fully support what patients really need for whole person, all around care.
Again, I'll call out, in our clinic, we have a care coordinator nurse, but yes, that's funded through a grant, right? And so it's difficult for a medical system to get enough money back to be able, just from patient visits, to be able to support that position. We also, again, occupational therapy, physical therapy, and a social worker. And then again, primary care to base it, and then depending on needs, again, neurology, and again, sometimes it depends on the specialists you have available to you, whether or not cardiology will be appropriate, whether or not a rheumatology will be appropriate.
In addition, I think, just echoing these same sentiments, I think that having clinicians on the multidisciplinary team who are long COVID interested is very important. I find that often, for example, patients will come to see me and they may already have a cardiologist, but it may be a cardiologist who is not well informed on dysautonomia or POTS, and so has done a comprehensive workup to rule out any cardiovascular disease, and then the patient has basically been told there's nothing here, so it has nothing to do with your heart, which may not be an accurate representation of what's happening. And so finding members of the team, the medical team, who, even if they don't have knowledge but are interested in learning and want to engage, is so important. At UCLA, we actually do meet every 2 weeks as a group of physicians to talk about the latest journal articles, to talk about complex care for our patients, in an attempt to try to create a cohesive model so that each person is not relaying a different set of information, but rather we're trying to build on each other's knowledge base. But I realize that this is only possible and feasible within an academic medical center, within a department that is very supportive of the fact that it carves out clinician time when they're not seeing patients to build this, and that this is not feasible in every community model. And I think this is the real problem, is that long COVID programs are now all relegated to the academic world, and finding actual help for our patients in the community, specifically if you're in rural areas or underserved, or perhaps just have an insurance that is not easily accepted in these locations, leaves, I would argue, millions of people without access to the appropriate levels of care. And on top of that, we're talking about a lot of individuals who don't know how to navigate healthcare systems. They're dealing with a new chronic medical illness. And it's one thing when I would say my patients who are over 65, who've had other chronic medical illnesses, have understood how to navigate the system and how it works, but I see many times patients who are in their 30s and 40s and, have families and lives they need to leave. And then on top of that are trying to figure out, how do I schedule this appointment and how do I conserve my energy? And I had a crash and now I need to cancel, and now the next appointment is 5 months from now. And this is just, I think, indicative of, what ails our healthcare system as a whole, which I realize is a different conversation. But this is unfortunately what gets placed on our patients, and it is a significant burden. And patient navigators are incredibly important, and they are incredibly expensive. And in a time period where you're talking about reductions in reimbursement rates and physician burnout and just provider availability, you're running up against all of these issues where it feels like you almost have to nickel and dime the insurance companies to get the care you need and have a health system behind you who will support that. And so, not that I have all the solutions today, but I think that realizing that this is what is going to be needed, and Dr. Petrino talked about this, but truly it is going to be a matter of engaging with Washington to understand, how do we actually move the needle for our patients with these chronic illnesses? How do we get the time carved out so that primary care doctors can more effectively manage these patients, that there are codes so that we can actually have the patient navigators, have these coaches, have the social workers, have all the things that are really needed to have not just have solutions for long COVID, but how do we move the needle and give quality of life to people with these issues?
I appreciate the fact that each one of you mentioned social care, which is definitely so important to integrate social care within a clinical model. And I'm sure amongst everything that patients are challenged with is also navigating systems and services and finding the right care. And I guess each one of you is fortunate that they work in big centers or at least specialized centers. But Dr. McCauley, for practitioners that have limited resources and small practices, if they want to replicate some of these models, what are some of the advices that you can give, and how can they overcome some of these challenges?
Well, I know one of our earlier speakers brought up the Bateman Horne Center and how they have wonderful resources online. That, just to begin with, there's an MECFS crash guideline for patients, or packet that they can have. And so there are online resources. There are, again, when we think about those community resources and associations like AMMES and again Solvemi and Dysautonomia International. So they already have a lot of great resources there. I know University of Colorado has been working on, in their rural connection clinics, actually using, again, lived experience patient buddies to basically help educate others and say, hey, here's the experience I went through, and again, here's some navigation tools for that. So that would be one thing I would think of. And then additionally, I think if you do have staff that is well trained but again has to have the capacity for it, even at the level of a medical assistant, If you can give them specifics about, okay, if this patient is calling and they're reporting, these new symptoms of they're feeling dizzy, lightheaded, or again, it's a pre-existing thing, and they say now they can't get out of bed. Here are our next steps, and usually in my situation, it's first, okay, can we assess how stable they are? Do they need to have, do I need to overbook to be able to see them on telehealth really quickly? Assess, do we need to try to figure out, I have not explored getting fluids in the home. We do have an infusion center, so usually if we can get someone to take them to the infusion center, we might do some rescue fluids. Or again, if things are not stable, then we're saying you might need to go to the ER, which can be its own issue, can definitely be traumatic and triggering. But again, our occupational therapists talk about how can we mitigate some of those effects. So just little, pearls are, wear sunglasses. The fluorescent lighting is triggering. Wear earplugs, right? And so yeah, that's my initial thoughts.
Great.
Those are all incredible. Additional things, maybe thinking more practically at the clinic level. So some strategies that can be more effective, for example, is arranging to have sooner follow-up with your patients. Oftentimes, primary care doctors do a lot of, I'll see you in 3 months, I'll see you in 6 months. I found that patients with long COVID, especially initially when we're trialing maybe new medications and having a lot of symptoms, to really help allay their concerns, to provide a lot of validation. It is better to see, I think, patients almost at a monthly cadence if it's possible, but go ahead and try and schedule it at the availability that is feasible, just so that there is a time and place that everything can be addressed. I found that many primary care doctors find it can be a little overwhelming when patients who were very healthy went to suddenly having long COVID. They may call very often, they have a lot of symptoms to discuss, and so just having that can be very helpful. Secondarily, a lot of physicians have some degree of discretion on how long the appointment can be, so even if typically your appointments are 15 minutes, saying, for this patient, let's try and book a 30-minute appointment. Let's really have that time that we can discuss. Or, between our visits, I'm going to have you meet with our medical assistant once just to do a nasoline test in clinic so that I can have these numbers for the next time that I see you. And or, do a 6-minute walk because I'm concerned that you may actually be having some degree of hypoxia. And it doesn't all have to be done that day at that moment. I've also found that there are providers in the community who will have patients, what I will say, take home these patient-recorded outcomes. It's basically the questionnaires. So take these home, do this on your own time, but filling out a fatigue assessment score, filling out a depression evaluation, filling out even just assessments for sleep apnea, but knowing that patients have brain fog, and so asking them to do this all within the confines of a 15-minute appointment may be doing both them and you a disservice, but having that information to help them not only help you take care of them, but I found a lot of those things can be really helpful in maybe even long-term disability claims, that you have this information early, that you documented it, it's been of long-standing nature, and so these are some strategies to consider.
Dr. Gang, anything to add?
I think this is great, yeah, and I just wanted to add that the AAPNR, the American Academy of Physical Medicine Rehabilitation, that Dr. McCauley mentioned earlier, in addition to their compendium consensus, which we're all also part of, there's about 40 clinics involved in this consensus group, that there's also resources on the website for other publications that came out for example, fatigue or neurological symptoms, et cetera, that have tables for testing or tables for considering of off-label therapies and other ways to support patients, as well as the ECHO models that were mentioned. And thank you to Dr. Pawson for listing some of the CME events also hosted by centers like ours. And we hope that clinicians feel free to reach out, especially to centers that have specialized long COVID care, so that we can create that partnership from the academic centers and to the communities and back and forth and exchange valuable bi-directional input and progress. So thank you.
Great, which is a good segue to my next question, Dr. Viswanathan. So we heard about the role of technology in some apps, and even somebody asked about AI, and maybe not as extreme to FaceTime a physician in Italy, but what role would telehealth and flexible models play into managing long COVID?
I think that telehealth and maybe the fact that it did, timing-wise hit with the pandemic has been a game changer in medicine. I think that it has now finally been extended, the timeline from Congress, to allow more patients to be able to do this. I think it needs to be made permanent. Patients should have this option, I think, indefinitely. The fact that we are contingent on cycles of our congressional leaders is doing a big disservice to the potential benefits that this will provide, not just for long COVID, but for all chronic care conditions. But in addition, I do think that there has been a lot of talk of expanding how we do home-based care. And when we're talking about patients who are bedbound, who are disabled this significantly, telehealth is great, but it doesn't completely fill the gaps of having an in-person interaction with your provider who can put their hands on you, who can evaluate your numbers, who can truly provide an assessment that is comprehensive. And so I think that there needs to also be an emphasis on how do we build this out. There was a waiver for home-based care. It went away. There's now some models that are coming back. But I do think that for long COVID, it is going to take this hybrid model to really ultimately, I think, really help our patients.
Dr. McCauley?
Yeah, I completely agree. Telehealth has been essential for long COVID care. I can't even think of how many patients would never have made it to our clinic, never have engaged in care because they just could not get there physically. I would also say about the home health piece of it is frustrating, and just to acknowledge also it really is payer dependent, and so it's not uncommon if we have someone who goes on disability for long COVID to have a period of time they're only on Medi-Cal before they can qualify for Medicare, and so Medi-Cal is very restrictive about what kind of services can be in the home if people qualify at all. So. Again, this is more policy level of long COVID being a diagnosis, as well as POTS, ME/CFS, that these are diagnoses that qualify you into additional services as opposed to baseline. Everyone just gets these services or doesn't get these services.
Thank you. Dr. Gang?
Yeah, thank you so much. I definitely want to heavily echo the importance of telehealth, and the ability to conduct that has been such a helpful avenue to be able to care for more patients and meet them where they're at. One of the biggest challenges, however, is that you have to work within your state. And so if there are any policymakers out there or those who are advocating, I think another huge barrier to people being able to, and this isn't just specific to long COVID, as I think about rare diseases, when you're trying to access a specialist in a certain area and that may not be available, especially in rural areas or underserved areas, and you're needing to cross state lines, that's where licensing and medical license practice capabilities end. And so it's really important for us to be able to understand as a country, how do we become more fluid and to be able to serve our larger populations, especially those who can't get to an in-state resource or clinic or clinician.
Great. So while we emphasize on the importance of primary care, and this is probably the first touch point where patients even start or they seek help and the role of primary care. But starting with Dr. Gang, when do you feel primary care physicians should start referring to specialized centers? And what is the most appropriate type of referral?
Yeah, thank you so much for that question. And I think this is all part of a broader push and initiative to try to empower and support primary care better. And we need to do a better job of that. So the answer to that question will depend on how well supported that primary care clinician is, and ultimately the patient who is in front of them and what their needs are. If they're early in their journey and the primary care provider is well informed and equipped to be able to support that patient and provide the care that is needed, and I'm hoping that that's more and more the case as we continue education, training, and availability of resources, that might be an okay case to continue to be in the care of primary care. Oftentimes right now what I'm seeing is that patients will try things with their primary care, or unfortunately, like I said, because of stigma or other things, get dismissed when they seek that care, then and need to advocate for themselves or have somebody else advocate for them to be able to be referred to a specialist. Oftentimes, they're not initially referred to us as a specialized center, but they may be referred to a specialist, for example, a neurologist or a rheumatologist, who then recognizes that this is maybe long COVID and refers them. Then that's where we talk about that fragmented care and patients bouncing around from doctor or clinician to clinician. But really, if we can fully support primary care, provide the resources and the education and the training necessary, I think a significant chunk of cases could be handled in primary care. However, I think it's always important that the referral pathways are open and available. And the team aspect, I still think, is really important. So that primary care clinician isn't alone, whether it's peer-to-peer support or referral network support. The problem with a lot of referrals, especially in large academic medical centers, is that it takes a long time. Admittedly, for example, we have a wait list, and others also have wait lists. Other specialties have wait lists. So in order to get the patient timely care, we need to bring that in a shorter time frame. And the way isn't to just wait for referrals to happen. The way is to pour the resources to be able to empower and expand the time that primary care can spend with their patients, and the support and resources that primary care clinicians can get.
Thank you. Anything to add, either one of you? All right. We're going to start with the audience, but before we do that, each one of you, what is one practical clinical pearl that you would want every physician in this room or those online that are here with us to take back to their practices when caring for patients with long COVID? Start with Dr. McCauley.
Yeah, I think I already had said it on my own practice of just having that preset idea of what are the criteria for ME/CFS. And when you start to get these patients who have, again, the fatigue, I've done the initial labs, I'm starting to get to the point where I think, this doesn't look like it's sleep apnea, it doesn't look like it's a low thyroid. I'm looking at that and putting that into context. So that would be my recommendation.
In addition, I think not being afraid to try treatments that are not FDA approved. I think that there has been a large amount of fear of the unknown, especially if you haven't learned it in your traditional medical education. These are doses you're not used to prescribing. You're not comfortable with potential side effects that may come up, because for many of our patients, we try them on the very first thing we try, and they'll suddenly have just life-changing results. And it is unfortunate that they've had to wait considerable time to get here when there has been knowledge about low-dose naltrexone or some of these other medications for POTS, that is available on, a lot of these platforms, UpToDate, Dynamed. They talk about these medications, so it's not that providers aren't aware. There is a genuine fear, and I've even seen it, I can't say it's just in the community, even in academic healthcare. I've seen providers who will reach out to me and say, can you prescribe this? A doctor started it somewhere else. I'm not comfortable with continuing it. And I think that's really unfortunate, especially if it's really helping our patients, is that I think for providers in general, it's learning that to do no harm has to include also being willing to be a little bit on the edge of medicine and accept a little bit of discomfort and risk. And that is okay, that is normal, and then you will get used to providing these medications, and you'll get used to the side effects, and there won't be as much fear associated with it.
Wonderful. Dr. Gang?
Yeah, thank you. One of the most common questions that I get as I talk to community clinicians and PCPs is, I can't remember all the different symptoms and the different syndromes. How can I recognize or diagnose or screen? And often in a 15-minute or really busy clinic, they're asking me for what is the screener question, because especially in primary care, we're really used to a specific screening survey or a 2-question type thing. So I go back to just the broad umbrella that also Dr. Petrino said, and really you're looking at a health status change pre and post COVID that they're not recovering from. And I know it sounds very broad, but it starts with that. And that begins the thinking process, and that begins the recognition and potential asking of additional questions and say, what has changed? And could that fit into some of these syndromes or other conditions? What kind of workup do I need to do? And those resources, again, I want to build empowerment and confidence that they are out there. And there's even clinician templates from a lot of the resources we mentioned for symptoms that you might want to capture that are the most common. And you don't have to memorize all of those. But if you start with the thinking of, has the health status changed, or does the patient feel different? You can ask the patient, do you feel different after you had XYZ infection? It can start that conversation and start that thinking. And then the resources are being built and should be available freely to then look further, dig further, and evaluate further.
Thank you.
Amazing.
David?
All right, we do have questions from the audience. We'll start with this young lady right here.
Thank you. Hi, my name is Elham Raker. I'm a pediatrician and a pediatric long COVID advocate. I work with long COVID families, and unfortunately a mom to a child with long COVID. So everything you guys are saying sounds amazing. Where are the resources for kids? We don't have any long COVID clinics for kids on the West Coast, let alone in California. I, as a pediatrician, have had such a hard time finding resources, I have to decide what treatments to give and when, essentially. And why I took up advocacy was for this reason, is if I'm having this much trouble, how are all these other parents doing this? And to your point of do no harm, before I give it back to you, I know CHLA has been marked as a long COVID clinic. Unfortunately, they are not providing care. They are only, yeah, we'll talk. They are only collecting data, right? My child has given her blood, sweat, and tears with nothing in return. So where is that for kids, right? We have 6 million kids in the US. That was the JAMA article that just came out. We can no longer kick this can down the road. And I'm here on behalf of my child, on behalf of all the other 6 million kids. Where is the help? We can no longer say, oh, just do whatever the adults do, or go to your pediatrician and show them the list. Not okay. So I'm reaching out to you guys, I'm reaching out to anyone else in this room that would like to help. I am willing to go to government officials, state officials, start, fundraising, but for what? Like, somebody needs to take this lead and say, UCLA, USC, Stanford, we will start a long COVID clinic for kids.
Actually, I'll take this one first, because unfortunately, CHLA is in the USC system, but pediatrics is totally carved out, right? So we do the adult medicine care, and they do the pediatric care. Correct. Not for long COVID, they're just collecting that data. So I do apologize. I wish we had better crossover between the clinics. And, again, and I think it's to Dr. Viswanathan's point, is that it's the comfort level too, and having those providers be more comfortable with initiating treatment as opposed to just kind of a watch and wait method. I know that the Kennedy Krieger Center is making big efforts. They have a lot of education available, but yes, I understand that is not translating to treatment here on the West Coast.
To this point with the pediatric long COVID, and I would say at least once a week, I am approached by a pediatrician asking if we are seeing children in our clinic. And I think the difficulty has been, at least for us, we are internal medicine, so training is really for 18 to the grave. And so therefore, we have cultivated that expertise in that age group. And I've had many patients now, as soon as they're 18, they're coming to see us. But I say this also, honestly, as a mother as well, it is horrifying the numbers of patients that are being diagnosed with pediatric long COVID without answers. One of the big things, and I do think this is probably going to be really dependent policy level, and two areas that I see being effective. I think the greatest success would be approaching our California lawmakers. There was a bill that was proposed a few years ago about building a long COVID centers of excellence here in California and having multiple academic centers be the holding of not only money for research, but for building out robust clinical care programs, both for adults and children. It has gotten nixed in a lot of budget talks. I had met with some lawmakers, and I don't think anything moved after that. And I do think that as we're being faced with, I think, challenges, I would say, around the country, we still inside of California have to remember we still have a very strong economic state, and at least here, I cannot speak to everyone else everywhere else, at least here we have the possibility of moving the needle, and what we need is a really robust coalition of not just physicians and not just patients, but we also need advocates in the form of getting buy-in from our lawmakers to bring this back, because I don't foresee this being solved necessarily outside of the state, but I do see maybe the state having a solutions that we could disseminate outside of this space. And so I do think there is some hope there, and I do think, I'd be happy to talk to you separately, but I do think maybe reopening these conversations is really what it's going to take, especially for our pediatric populations.
Dr. Gang?
This is such an important area, and thank you for sharing your personal experiences and the echoing the sentiment of advocacy that's much needed here, not only for the care that's lacking, but also the research, because children are not just little adults. And so I think part of the Recover Initiative, of course, has the pediatric cohort that's sponsored by the NIH to understand the clinical manifestations and other aspects of pediatric long COVID. We're also currently now part of the Recover TLC, which is treating long COVID, the next phase of the clinical trials that will be coming out. And for example, we'll be studying low-dose naltrexone in children and young adults. And this is so important because as you're talking to pediatricians about being empowered and feeling comfortable with treatment, they're going to look and want to know for the evidence that's there. And there is very, very little research, especially clinical trials, that are being done in the pediatric population for long COVID and other IACCs. So I think there's a huge gap and huge need there. And for care, I hear that as well. We've been lucky enough to recruit somebody who's been able to see adolescents age 12 and above for our long COVID care clinic. But I know this is an area that really needs robust increase and support for the children who are suffering from this condition. I do want to put a plug in for Dr. Laura Malone's program at Kennedy Krieger Institute. They are part of the ARC initiative, and they've been fantastic on the pediatric front to create resources, again, for that point of making democratizing the knowledge so that other clinicians in the community and other pediatricians who aren't necessarily long COVID specialists can help care for their patients, meet them where they're at. And so I encourage providers who are taking care of children to look at some of the resources that are also out there that are now being created to support care for pediatricians as well as patients with long COVID who are children and young adults.
I think it's important also to acknowledge that just us being here and for the third year in a row addressing long COVID is a good start for all these efforts to start coming together and establishing something beyond just talking about it. I have to give credit to Chesley that 3 years ago when we had our first meeting, and it was in this hotel, but I think in the room above, we did talk about establishing a West Coast Center of Excellence, taking some of the work that Dr. Petrino has been able to do and maybe a blueprint to establish something even here in Santa Barbara. And those talks are still happening. I think bringing us all together and all the stakeholders and all those that are interested, and as you said, advocating for it, but also availing some of the resources, especially with health centers and practitioners that are in the state and highlighting some of that work. I do believe that this is doable, and it's something that I know Chesley will not leave us without accomplishing it one day. Hopefully I'm still around when this happens.
Doctors, we're going to bring this panel to a conclusion. We do have the patient panel coming up. Thank you so very much. Some incredible information. We're going to take a quick 5-minute break, and we're going to be right back with the patient panel. So if you do have a moment to go get some air, use the restroom, grab a drink, and we will see you back here in 5 minutes' time. Thank you very much.
Okay, I'm Lindsay Leonard, and I just want to thank everybody for being here as we begin our patient panel for our CME accredited event. I've been working with Chesley for the past 2 years, supporting the Chesley Initiative, and today I have the pleasure of moderating our patient panel, and I'd like to introduce our panelists. I'd like to begin by introducing Dr. Josephine Solis. Josephine, on my far right, is a former physician who practiced in Ventura County, and she is now uniquely positioned as both a patient and a medical professional. I'm going to take a pause. Islay, how are we doing? We're so grateful to have her because she's able to offer a dual perspective in her role as a patient and a medical professional. I'd also like to introduce Lisa Maglione. She is a retired local principal who has led a very active life as a swimmer, hiker, and traveler. She brings data-informed lens to her experience and has definitely applied her own research-based approaches to navigating her journey with long COVID. Next, we have Polly Sumner in the green. She's a longtime Santa Barbara resident and nonprofit leader. Polly has led a highly active life and is a mom to an adventurous young son. She previously lived a very active lifestyle, which I know she'll touch upon, and has also authored several articles chronicling her own experience with long COVID. And joining us today virtually is Royal Hanson. Royal serves as the Vice President of Privacy, Safety, and Security at Google, and has a background in financial services and technology startups. So really, before we begin, I just want to set an intention for this conversation, which is that our panelists are not here to share their full story, and nor are they here to represent every patient experience, because as we've heard time and time again, each patient's experience is very unique. I do want you all to, and I invite you all to share what you feel is essential for physicians to learn about today. And of course, if at any time you want to pass on any questions, please feel free to. So to kick us off, I'd like to pose a question to each of the panelists, which is that, as we know, everyone's experience is so different. So I'd like to ask each of our panelists if they could share a little about their journey, what life was like before you or your family member became ill, and how it has changed since then. So Polly, would you be able to get us started?
Sure.
Hello.
Whoa. Okay. Thank you for having me. I am not a public speaker. Before I got COVID about 4.5 years ago, I was a very active person. I was busy raising my young son, volunteered at school, worked full-time, and I was an ultra-marathon runner. I was firing on all cylinders and the strongest I had been in my life. I was excited to get up at 4:30 or 5 in the morning and go do a 10-mile run in the mountains before starting my day. I was invincible. Then I got COVID, and although I had a mild case by medical standards, the aftermath has been anything but. And I should say, as an athlete, I had read a handful of articles about other athletes getting long COVID. So when I got sick myself, that was my greatest fear. About 2 weeks after the acute phase of illness, I decided to go out and try a run, and it did not go well at all. I had an elevated heart rate, dizziness, I was breathless at sea level, and just had a fundamental sense that something was seriously wrong. Shortly thereafter, I had about 30 different symptoms manifest, and thus the nightmare began. So how has my life changed since? Well, I'm certainly not going out and running 10 miles before breakfast anymore. In fact, I'm lucky if I can walk 1 to 2 miles every so often. I essentially have become my body's risk manager, and by that I mean I need to be very intentional about my energy output on all levels, emotional, mental, and physical. I have to stop and ask myself, what will be the likely outcome here, and is it worth it? So I've gone from a very high-octane, fast-paced life to dead in the water to now a very deliberately crafted existence. And that's been a very drastic shift. But that said, I am really excited to be upright and lucid and here to share. So thank you.
Thank you, Polly. Lisa, how has this experience been for you? Could you share how everything was before and how it's changed for you?
I've written out my responses because when I get excited and start enjoying things, and I value this, my heart rate spikes. I'm wearing my Visible, and it makes it easier for me to read. I'm grateful to be here, vertical, functional. Thanks to Dr. Petrino's core clinic and my team of UCLA, Stanford, Cottage, and Chesley and my husband, I owe you my life. My life before COVID, we were living a dream. I'm a principal educator for 38 years, and my husband and I had retired and moved to Italy. 5th story walk-up, 4-year contract, 15,000 steps a day. Language school, wining and dining. We were enjoying a very full, spontaneous life. Santa Barbara, paddleboards, bikes, and I did swim 60 laps in 45 minutes on a regular basis. 3-mile walks, and a proud leadership coach for the state of California administrators. Life erased that life 2.5 years ago. Did I say life or long COVID? Welcome to brain fog. A year ago, I was 5 months severely bedbound and on palliative care. Horrific long COVID symptoms, internal tremors, extreme body temperatures, volatile heart rate, and blood pressure, sensory overload. I could not tolerate light, sound, touch, or my daughter's hand. Adrenaline dumps, hallucinations, writhing in pain. A 20-minute doctor conversation virtual would leave me crashed for days or weeks. Yes, no questions became difficult. I only could speak 3-word sentences, unlike me. Full-time caregivers fed and changed me. On liquids, the visiting nurse considered hospitalization. She told my husband, "You don't want her to die here." Bill and I cried together every night. We said everything we needed to say to each other that needed to be said, and my dear husband was collapsing under the weight of this unknown illness that no one had a lifeline to. My FunCap functionality physicians was 0.7 out of 6. Only about 5 people leave this level of ME severity, and I was absolutely terrified. But I sit here with a message of hope. There is recovery of some sort. I had a year and a half of 10 prescriptions, 5 off-label drugs, all in the practitioner's manual. Start reading it tonight. And also, I have to shout out to CORE's Autonomic PT Cottage Rehab. They work together with CORE and here in Cottage to help me bring my functional level back to 5.8 out of 6. I have $1 of energy to your 10. Daily pacing, chunking my cognitive, social, physical, and emotional energy is essential. Visible helps me choose 1 or 2 activities a day to avoid evil Pam. I can wash my hair once a week and take 20 minutes walks now and 30,000 steps to Shoreline. Reinfection could make me start all over. No aerobics, no laps. I live knowing this recovery could change any day. Thank you.
Thank you for sharing. Josephine, may we hear from you?
Yes. So I did not start out with long COVID. I got diagnosed with West Nile virus 6 years ago. It's actually endemic around here, not common. And then 2 years later, I got COVID and I got worse. Before I got sick, I was a family doctor. I loved my work. I found it really meaningful. I had lived in the same place for 40 years. I had a lot of relationships, shared history with lots of people, and I really enjoyed my times spent with friends. The first 2 years after I was sick, I worked. I had loads of accommodations. I probably got done in 8 or 10 hours what another physician would do in 2 or 3, and I finally decided that my partners were doing all the heavy lifting and I should retire. So now, or since then, life's a little lonely. I'm someone who enjoys her solitude, but I get more than I want. Typically for me, I do a single 1 or 2 hour activity a day. I make 1 cooked meal from scratch, usually. The rest of the time, I do guided meditations, I do breath work, I embroider a little bit, I study my illness and related illnesses. I communicate mainly asynchronously. I find the phone or even one-on-one pretty tiring, but I do email and text. I do a little bit of exercise. Used to be mat work, now I'm walking a little, and I've actually improved some in the last several months, and I'm working in some of the stuff my PMR doctor recommended. One of the things I do that's kind of meaningful is when the opportunity arises, I help other people with the same illness, usually prepping for doctor's visits, how to make them as effective as possible, and also helping with disability forms. So that's me.
Thank you. Royal, I'd like to ask you, what has it been like for your family?
Yeah, that's great. You can hear me okay?
Yes.
Great. Well, first off, thanks for including us as a family, and having heard a little bit at the end about children. That's our story. So just as a sort of level setting, we had a just turned 10-year-old in the end of 2000 get sick. We all got sick, and the last 6 years have been just at a high level, a steady decline from a boy who was playing tennis, baseball, going to school, rock climbing with his older brother. And we could talk more about the diagnoses, but went from little by little to POTS to dysautonomia to sort of some combination of what you're all talking about here today with long COVID or MECFS. But our son, while sort of active through those first couple of years, hasn't been in school since that fall. He spends most days lying down in a dark room, with sort of off and on ability to interact in ways people were describing. And in a weird way, I mean, it helped that he was young active boy because people were tuned into that and didn't believe that he would just retreat from life the way he has. But little by little, everybody forgot about him, just because boys and families are busy in this era. And actually 2 years ago, I sort of pulled back from work a bit because my wife had been in the way that was just described with pediatrics, the sort of nurse, doctor, and research finder for, and 24/7 with him. And so we moved back to Utah, actually, so I'm sympathetic to the California question, where I grew up, and we were around our family in Bateman Horn, and have found some combinations of help there, but basically he's in the same place. Not in school, doesn't see people very often, and we're basically home all the time. It's a little bit surreal. We do the best we can with it, but you wouldn't. One thing that's sort of hard, and I wonder other patients, nobody really gets it if they don't see you. They wouldn't believe that you just sit home all day, taking care of someone who's not just tired, but sick all the time. So that's our story as a family.
I can imagine it's very difficult to witness and support a child. It definitely hits a lot differently when it's a child. Royal, as a follow-up, can you tell us about your family's journey with getting a diagnosis and finding treatment? What was that like for you?
Yeah, it's I was thinking about it as others have described, even the medical industry around this. The first year or two, I guess we were lucky in a way that within the first year, somebody figured out the POTS, but that took a pediatrician in a three-way relationship between us, the pediatrician, and each specialist to sort of knock into that diagnosis, because we saw all kinds of immunological or neurological or other sort of specialists as they ruled things out. And POTS was the first thing we got, a named diagnosis, but as we all know, it's sort of a condition, it's the symptoms, not the actual disease. Maybe a year or two after that, we got a dysautonomia kind of diagnosis from a neurologist and tried to look at that. And it's only in the last, since we've been working with Bateman Horn, that it sort of thought of more holistically in this long COVID ME/CFS. We sort of knew we were always in that category, but I really feel like there's very little in the way of biomarkers, like you all know this better than I do. So those were POTS, dysautonomia, and then random inflammatory markers, but nothing that would qualify for anything other than this sort of broad category of a disease.
It certainly sounds like it was quite the process. Josephine, can you share, what was it like for you getting that diagnosis and navigating care?
Well, when I first got sick in April 2020, medical systems were super stressed because it was COVID. And I got sick at work. I went home and I was sick for a few weeks. I thought I had a random virus with encephalitis that wasn't bad enough to be hospitalized. And that was kind of it. I went back to work and discovered I wasn't functioning very well. It was about 6 months later that I actually got diagnosed with the West Nile virus. And even then, I didn't think in terms of a infection-associated chronic illness. I thought I'd had something static. I thought I was recovering from encephalitis. And I really don't think any of my doctors saw it any differently either. It was really a couple of years ago when I have a doctor friend who is really ill with long COVID, And she would send out things she was learning about in group emails, and I started reading what she sent, and I thought, well, that's me. And I got introduced through her to the Bateman Horn Center. I listened to a couple of experienced clinician podcasters out of Seattle that gave me a lot of pearls. And then those two resources took me to all sorts of other resources. I liked Peter Rowe at Johns Hopkins. I liked Dr. Raj at the University of Calgary. Got a lot of great ideas. I started going to the bibliographies and reading the source material. I started printing out articles. I'd take them with me to my doctor's appointments. My family doctor, super supportive, not knowledgeable at all. My specialists were really pretty helpful, but they all stayed within their own field, so the neurologist didn't talk to the cardiologist. My husband said I was my own case manager, and basically with self-education, self-advocacy, I got my diagnosis of autonomic dysfunction. I got diagnosed with small intestinal bacterial overgrowth. I got diagnosed with small fiber neuropathy. I again, asked my physicians for and got low-dose naltrexone. After the beta blocker I asked for failed, I got clonidine, which worked pretty well for me. I got a pro-motility agent. And I pretty much did the compression garments, fluids, and electrolytes on my own with home NASA lean tests. I have to say, the abdominal binder, which I just started in October, was like a game changer for me. And I am 2 or 3 hours more able to be upright per day. I just love that thing. I only met doctors who had actually seen people like me in the last 9 months, subspecialists at UCLA, and they've been fabulous. I didn't mention that I had some weird limp spells with altered consciousness, and my neurologist started me on seizure medication. It kind of made sense. There was no other explanation. It's a known complication of West Nile virus. And I didn't want to hurt anybody on the road. But when I finally saw someone who saw patients like me, she said, I don't think you have seizures. And I got into the UCLA Epilepsy Clinic and had an ambulatory EEG and got tapered off that medication, which was great. It really was just the orthostatic stuff. If you don't see long COVID or IACC patients, you might be surprised how many things we are willing to try. And I've really tried everything that I thought was rational and not very harmful. So I do breath work. I monitor my heart rate variability. I do meditation. I still do those things. I've tried a few supplements. I did vision therapy. I did EEG biofeedback. I saw a PT, unfortunately not knowledgeable about PEMS, so it really backfired. Currently, I'm trying out a vagal nerve stimulator and red light therapy mat. I was kind of interested in trying rapamycin or IVIG or plasmapheresis, but that's not something to do on your own. And when I finally saw these people who knew about autoantibodies at UCLA, they didn't recommend it, and I trusted them. I do want to do one kind of shout out for the clinical applications of Dr. Stephen Porges, who's a vagal nerve researcher. I did his 2 protocols, and they really helped me. My phenomenal insomnia really dramatically improved. And then I had this other thing of having random crying spells that were just so embarrassing and did not seem to be related to depression. And after I did Dr. Porges' Safe and Sound protocol, they just disappeared. So I suggest anyone who's interested to look into that. And that's it for me.
Well, that's a lot. And it is a lot that so many patients are going through. And being here today, it's obviously our greatest hope that we're going to be able to better improve the ability for physicians to diagnose and treat. However, for our other two panelists, I would like to give you an opportunity. Is there anything additional that you would like to share about your experience receiving a diagnosis and accessing treatment? Would you like to go ahead, Polly?
I think you covered it pretty well.
Lisa, is there anything that you would like to add or that is really notably different in your experience?
You know, there's a couple points because they were pivotal in my journey. I do like researching, and I was really grateful to find Dr. Petrino's slide in the Montecito Journal 2023 article that led me on my path. And I took this slide of his to all my doctors, and I said, I want to do whatever you think I should. And that started my path to knowing his clinic. I had gone to the UCLA clinic. They weren't quite sure that I fit the criteria at that time of long COVID, and had put forth some additional testing that we would do to make sure that I didn't have other things. And then in research mode, my husband and I flew across to Dr. Petrino's Mount Sinai Core Clinic, and over 5 comprehensive tests, 4 hours, and I wish it existed here, I was diagnosed with long COVID, hyperadrenergic POTS, dysautonomia, mitochondrial dysfunction, lowered aerobic threshold, and told to visit cardio. The pivot point is when I came back, and we didn't know this was going to happen, I went to my nerve conduction study that UCLA had prescribed, and unlike perhaps other people, 4 days after the study, my body completely shut down. The test was way too aggressive for my body. That was the first of 3 ambulance rides I had that week. I also think it's important in anybody in the emergency care situation to be advised of what it means to have long COVID, because my last ambulance ride, the EMT kept asking me my name over and over and said, Miss Lisa, spell your name. And Maglioni's a long name. And several times, and I was sent to psych first to make sure that I even qualified to go to the ER, and ended there next. I just want to say, Vishna, Dr. Vishwanathan, she and her staff spent 5 months with me every week virtually to get my meds dialed in, and they're working now. But at the time, I wasn't responding to treatment. So in true form, this team approach to dealing with us, they suggested that I go to Stanford. So I'm thanking Stanford, who started me on higher doses of LDN. That was a 6-month wait. So in between, we went to private care and ended up with trials of Celebrex and acyclovir, game changer. All pain gone, and I was writhing for 5 months. 2025 brought hope. Dr. Petrino and Chesley made a home visit because days were really, really dark. And we ended up adding propanolol, and we have local champions here. I want to tell you, I got Dr. Petrino's autonomic PT rehab. It's all in the manual, and got VNA nurse to do home care PT with me, and that's what got me out of bed. I recalibrated my autonomic nervous system, and then 10 months, another local champion is Cottage Hospital Rehab Services, PT, OT. They know PEM. They can take care of you. I've been with them for 10 months. They did speech and language cognitive therapy with me as well. So we do have resources here that we can count on.
And it certainly sounds like you had quite a team of doctors, and I'm seeing that as a consistent thread with our patients here today.
Can I just follow up on that one thing on all these things we try, because as I hear the patients say this, and it's particularly hard with kids, is yes, there are lots of things to try, but that leaves us as parents or as patients trying to figure that out. And like one of the physicians said earlier, we're totally willing to try new things, but the matching of a patient to the solution is so anecdotal and hit or miss, and it can get worse. This is the thing nobody told us about in the beginning. And then you eventually meet people who are not speaking and being fed through a tube. And you realize that even some of these things, I know some of them don't cause problems, others do, but our son has slowly just been, won't believe us with the next thing that we want to try, because they've all either not worked or made him worse. And that's the thing that is so hard about this, is the science behind the matching of a subclass of symptoms or condition to the solutions is not well mapped.
Royal, I think that's a really good segue for us to go into the next question, which is, what is the one thing that you feel physicians could do differently that would have the greatest impact on patients living with long COVID?
I'll just to follow up on that real quickly, and then I'd love to hear the others, he was more active in the first few years as we tried to circle this in ways that I think ultimately trained him and put him in a worse place. And so if we had been more cautious and more cautious is probably the word, earlier, maybe we would have maybe able to maintain his baseline higher. I have no idea, but that was certainly not something we were thinking about in the first couple years.
Understandably, as this is so new for so many people, even though infection-associated chronic conditions have been around forever. Polly, I'd like to ask you that question as well. What is one thing you feel physicians might be able to do differently that would really have the greatest impact on patients living with long COVID?
Sure. One thing I think would be beneficial, especially for new long COVID patients, are some mental coping ideas. I really was not given any, especially in the first year of seeing doctors and specialists. And a few that I came to organically on my own were meditation, CBT, diet change, joining a support group. I joined an online international support group for endurance athletes, and one of the moderators is actually here today, Courtney Baker. And but one thing that really helped my psyche was I got myself a handicap parking placard. I'm too young for that, but I was having a hard time walking even short distances. And as a result, I was missing out on a lot of life events, and that only deepened my depression. For example, my son's school has a very small parking lot, and you always have to park farther afield and walk. And I was too embarrassed to ask people to drop me off, and that was my own thing. But once I got that pass, I found I had the confidence to get to the geography bee and student of the month and the school play and not be completely terrified that my body was going to break down. For me, that was a huge emotional lift, and something, it cost, I think, $6, but it completely reintroduced me back into the world and out of isolation.
Lisa, I'd love to hear if you would like to just briefly illuminate anything that you truly feel that physicians could do differently that would have a big impact on the patient experience.
I'm thinking about all the questions we are getting from audiences in the bathroom. What did you do? What did we do? I think if we could gather a patient handbook that would be of education, of these are good resources for this, or this is a diagram that can explain, simple diagrams. In our schools, we have like, welcome back to school, and this is what school's about. Well, it's a little bit like, welcome to long COVID, and this is what it's about, in a very generic way, because patients and their families many times don't have the capacity or the facility or the energy to do this research. And if I were handed, or any of these parents who have asked questions, or individuals, you know, how do I get rid of brain fog? What could I do to PACE? What mental health things are around in the community? What are some links and handouts that can help explain to me, and maybe graphic organizers? I was looking at this and I circled the 7 that pertain to me. You know, ways to make communication easier with you and your doctor, or the doctors with you. Stanford has a great ME/CFS severity line, and I went, oh my God, I can tell my doctor, I'm at level Z on this, you know. I think just having a long COVID patient education handbook, that comes from my education background, I think, would go a long way and give a lot of sense of control and help while they're waiting for that 10-month appointment.
Spoken like a true educator. Good insight. Josephine, is there anything further that you would like to add?
Well, I couldn't resist coming up with 3, but they're quick. I really liked what Dr. Putrino said about systematic assessment. I really see this illness as an illness of multiple dysregulated systems that all play off one another. So if you treat one thing, the other things get a lot better. You know, you treat the SIBO, the autonomic dysfunction, it doesn't flare as much. So I really think patients tend to bring up what's bothering them the most, and they may not bring up something that doesn't bother them that much, but really could benefit from treatment. Second is, I'm super big on disability, and even doctors who think, I cannot take this on, they can still fill out disability forms. And if you get disability, it promotes recovery, it decreases misery because you can rest when you need to, and it totally decreases financial worries, which are a big deal when you can't work. And lastly, I feel kind of militant about CME, continuing medical education. I mean, I was working when AIDS came out, and I couldn't believe how many physicians said, I didn't sign up for this. And I thought, well, yes, you did. You signed up for whatever turns up in the world when you're a doctor. And I feel the same about long COVID. I just saw in the LA Times that Public Health says there's 178,000 people in LA with long COVID. And so I think, why shouldn't the CME be mandatory? I mean, it was how many years ago that we all had to take pain management or we couldn't relicense? Why not have that be the case with long COVID? You know, even 3 hours of CME would make a difference. So that's my 3 things.
Well, that's some really great input. And I just want to touch base. I've just a couple quick more questions I wanted to ask. One, just to better deepen our understanding of what it's like for that experience for kids and teens is, Royal, is there anything that you feel with physicians in the health systems that can better support pediatric, teen, and even young adult college age patients?
Yeah, it's such a good question. And I learned a lot in this on this journey. And one of the physicians said earlier, and I think there are good reasons for it, the way we treat children not like little adults. And I know that you know, there are lots of good reasons for that. But man, does it make it hard to navigate the system. You sort of have to bring a chaperone, your pediatrician, to all these specialists. They don't exist in those combinations for each subspecialty with the pediatrics. So I know the mother who had a question earlier, very empathetic and sympathetic to that plight. So that's one. The other is, you know, when you're a child and you get this at 10, it's very different than having it at 16. all of a sudden life was taken away in ways that he was still just learning to be a child, let alone being a teenager. And it took years for him to kind of come to grips with the loss and the therapy, but this is not the same as being an adult and going through this and coming to grips with it. I've really struggled to find a way to help him be optimistic when basically it's been a horrific robbing of his life, and he doesn't believe us anymore that it'll get better. And so I don't know how you navigate all that, but that's the reality for a child who gets this.
Understood. And it is a lot. Before we wrap up, I just have one final question I'd like to ask of one of our members, Polly, which is, we heard from you about how you've had to make significant adjustments in your daily life. Is there anything that you've learned from living with this chronic condition that you'd like to provide to us as a takeaway?
What haven't I learned? In all seriousness, this has been the most profound learning experience of my life. Also the most painful, but also gratifying too, strangely. As an athlete, losing that ability overnight was horrific, and interesting how I hear us all using the word horrific. But it was never just exercise for me. It was meditation, therapy, stress release. It was my social life, a bonding activity with my son. I loved racing and the competition. So to lose all of that in one fell swoop was, it left a huge void. And of course, the first natural progression from that would be acceptance. But nope, I resisted, especially in the first year. I pushed too far, too fast, too hard, and I got worse. Go figure. But if you get knocked down enough times in the same way, it finally starts to sink in, and eventually it did. And I've learned that accepting this version of me and adapting to my limitations was really the only direct way forward. And for me, the silver lining in having a chronic illness is seeing the growth and change within myself. My perspective has completely changed. And I've written about this. I've been published a few times, which was incredibly vulnerable, as has been having to use a wheelchair in the airport to travel, or let my family do a GoFundMe, or being heckled by other athletes when I'm on my e-bike. But those are all just trivialities when I compare them to the gratitude I now feel in my moments of good health, which do happen. And when the body is at peace, mwah, what a gift.
Aw, what a beautiful share. I would just like to take a moment to just really thank each Royal, Josephine, Polly, and Lisa for sharing their courageous stories of their own experience. I'd like to now conclude the patient panel. And if each of you would like to take your seats, David and I are going to wrap this up in a few moments here.
I hope we're all leaving here with a little bit more knowledge and feeling a bit healthier.
David.
Yes.
So we know, right, that we've been here for a long time today.
All day. And it's been great.
And so we want to share just a few things. One, all attendees are going to be emailed a survey and a quiz by the California Medical Association. This is going to allow you to receive your CME credits. Oh, yes. But please do give CMA some patience, a few days before you might receive that email. So this officially is going to close the CME accredited portion of today's forum. So give yourself a round of applause.
Yeah, and thanks to all of our speakers, sponsors, and supporters, and to each of you for being part of today's forum.
But I have some more.
But wait, there's more.
And we're going to tag team here. So I just wanted to share a couple of things. And one is that in addition to those of you in the room, I just wanted to give you the wow factor, because we haven't shared this yet. So as I looked at all the participants, I just wanted you all to know that we had not only all of us here, but we had joining us today virtually people from Canada, New Zealand, Spain, the UK, Japan, Switzerland, and by last count, at least 29 different states represented. Wow.
Hello, world.
So this clearly shows there is interest in learning more about this subject and the greater need. And as Dr. Petrino spoke to, there are hundreds of millions of people that have struggled with and or are still struggling with this debilitating chronic condition. I had never imagined that I too would be one of them. And that's why I'm here today. So I'm asking you, along with our fabulous Executive Director, Chesley, for each of you, no, really, each of you, to do something to further this cause. One is to please share this with your colleagues. We will have the virtual recording of this on the Chesley Initiative website, as well as on the Chesley Initiative YouTube channel. I am also asking for each of you to consider getting involved as a physician champion or joining a roundtable. You can contact us at the Chesley Initiative again. And lastly, to support the work that we're doing here today, to support today's forum, and to support continued education, do feel free to either volunteer your time or consider making it a gift. The Chesley Initiative is a 501c3 nonprofit, and any and all donations are meaningful, regardless of the amount. So I just genuinely want to thank you all for your time today.
Thank you, Chesley. Thank you, Dr. Petrino. And thank you all for attending today. You'll have a spectacular weekend. Wishing you all health.